I would request Mr. Ray, Mr. Basu, Dr. Basu, and Mr. Dasgupta to please join us on the dais. I would request Mr. Gautam Ray, President, the Bengal Chamber of Commerce and Industry, to please formally welcome all.
Good morning to all of you. Dr. Rupali Basu, Managing Director and CEO, Woodlands Multi-Speciality Hospital, as well as one of the very renowned leader in the field of health sector in the country. Mr. Rana Dasgupta, CEO, Eastern Region, Apollo Hospital Group. Mr. Arnob Basu, President Designate, Chamber of the Chamber, and dignitaries of the dais and the delegates, guests. This is, of course, a flagship event of the Chamber, and the 7th edition of this Health Tech is being organized here in Kolkata today. The addition this time is that in the Chamber, we decided, keeping track with the industrial development, what is happening all across, that we included a subcommittee or expert committee on biotechnology and pharmaceuticals, because this area is very, very developing, and biotechnology probably the future of the world, including the infusion of AI, as well as it has gone to the roots of various other sectors. So there will be a special session today on biotech, and we are really trying our level best to promote the industry based on that biotechnology as well as the pharma, which is, of course, is not that way present in this part of the country. Another focus area where Chamber is working to, particularly this year, of course for last couple of years we have been working on, is the sustainability. Sustainability is one of the major focus of the Chamber now. In fact, in the last held BGBS, there had been first time a sectoral session on sustainability, which Bengal Chamber has been entrusted to organize. In fact, in the Business Summit, such a session, probably first of its kind. And you all know that with this agenda, not only in the national level, we had our presence in the international level. We, in fact, organize events in the COP26 also, Glasgow, where all the head of the states gathered there, had taken some very tall commitments on cleaning the world. There are net zero, etc. And this sustainability has a major goal. Third goal is on the healthcare well-being. So on one way, health industry is growing very fast, health sector. That we will listen to Dr. Basu and Mr. Dasgupta, of course, and also with from Arnob on the subject. But I would say that keeping track on that growth, what is happening, we also need to see that the affordability and how it can reach to the millions of people. That's also important in today's aspect to attain the sustainability for which entire world is looking for. So I hope that there will be a very, very detailed discussion on that. We will have the recommendations, and we have decided from any such type of events we will organize, we will try to prepare something as a recommendation for policy advocacy. We have recently formed a sustainability forum also, on which we are working. And I hope that this deliberation, this flagship event will be very, very successful. Make it as interactive as possible and enjoy your stay here. Thank you.
Thank you, sir. May we now request Mr. Arnob Basu, President Designate the Bengal Chamber and the Chairperson of IT Committee of the Chamber and Advisory Leader PwC.
Good morning. It's always a privilege to be speaking at the Health Tech. As Mr. Ray was saying, this is the 7th edition. It's also been PwC's privilege to be associated with this since the first edition when we started this along with the Chamber. And I think when I think back about the 7 years and what we have been talking, it definitely fills me with a lot of pride around how we could bring some of the topics to the fore in terms of what's happening around health, around technology for health, and around better care, medical care for our people across the country. Now, if we think of some of the digital trends which are shaping the Indian healthcare today, I think you would probably feel pertinent that the biggest one which is disrupting us today is AI. And when I say AI, I mean broadly artificial intelligence and not only generative AI. We have been talking a bit more about Gen AI for the last 1 year. But if you look at broadly AI and how, general connectivity with devices, Bluetooth operated devices, what it's doing to around, to healthcare and patient care, I think the impact has been significant. And if you look at mobile health or mHealth as we call it nowadays, mHealth solutions are gaining in popularity. I think the broad use of smartphones in India has made it accessible to many. From Internet of Things, now we have gone into Internet of Medical Things as a specialty topic. And if you think of, the various smart devices, whether it's around wireless inhalers, around smart beds, around different machines, real-time tracking of high-risk patients, I think this is going to a completely different level. And I was at the Mobile World Congress earlier this week, and I think what's now happening on Internet of Things or Internet of Medical Things you would see is that as AI is getting inbuilt, we have learned around edge computing, and we know about Internet of Things. Now what we are seeing is that this is becoming AI at the edge. So rather than pushing every data from every device into a central place, as we were doing, I think as AI is becoming far more, developed and far more accessible, along with, 5G applicability and 5G availability, you would then see that you don't need to send everything back. You can do, the artificial intelligence can actually do it at the edge, and then only some things can come back. The rest can happen much faster at the edge. And that I think is something which would probably, take over because, data has been ubiquitous for some time. We have been thinking about how data, can be moved around. But then if you're really thinking of very large volume of data, AI at the edge would probably make the next big jump. The other thing which has happened in India is, of course, the adoption of electronic health records and, overall the interoperability between systems, between standards. And I think the efforts to digitize the health records and improve the data exchange between the, providers is likely to accelerate. I think this is something which will see far more progress in the coming days. And India is a very, very thriving, I would say, source of Indian healthcare startups, digital healthcare startups, which bring in a lot of innovative solutions. So again, we'll probably talk a few of those today during the day. You'll learn about them. And as they work around these disruptive technologies and novel approaches to adopt healthcare challenges in areas, it could be around telemedicine, it could be about remote patient monitoring, it could be around chronic disease management and healthcare accessibility. So I think all of these will play a huge role. The Ayushman Bharat data mission, digital mission, I think that has been another big government of India initiative to, establish a unified digital health infrastructure. And you would see that once that becomes a backbone for an integrated digital healthcare delivery. The other thing which has happened as a trend is the NABH coming out with its first edition of the new accreditation standard, the 182 objective elements and how they have been spread across the 8 chapters. And of course, they have been divided into, core, commitment, achievement, and excellence. And I think it would allow us to look at the digital maturity and, the different levels of maturity as they have, sort of silver, gold, platinum as they have been defined. And if you look at the paper which we are releasing today, just a few pointers, you can obviously, I won't steal the thunder from Shayantan and the others who have really worked on it. But it is around the outlook of Gen AI in healthcare, the opportunities, the perceived risks and challenges. It also talks about, the entire thing around care delivery, around medical and patient education, operational excellence, drug discovery, and many other topics, and how Gen AI can have a role to play in all of these. Also, we have tried to capture some of the risks around this, some of the challenges, and how the road ahead is looking based on our understanding of how the technology is improving. So overall, we have a power-packed day of different kinds of speakers, and we have 2 very eminent speakers who are doyens in this field, and we'll listen to them to understand a bit more. As many of you who know both me and Mr. Ray, we are not from the sector, but we'll listen to 2 specialists from the sector to understand what's happening in cutting-edge healthcare. So with that, again, thanks for making time for this. And as always, it's a privilege to be here and listen to the specialists. Thank you.
Thank you. We would now request Dr. Rupali Basu, Managing Director and CEO, Woodlands Multi-Speciality Hospital Limited, to please share her presentation on future of healthcare management trends in digital advancements.
Good morning, everyone. Future of healthcare from a, I'm going to talk on the on behalf of the, how do I say, it's from a person. Health is, if I look at it from a person's point of view, that a human being, which is like all of us are here, we are well, we are seated here listening, and then someday we might be unfortunately have some, somewhere we have to need a doctor's help or get admitted for a surgery or something in a critical care unit in a hospital. And probably when we grow old, we might, or post-surgery, we might need some special care at homes too. So if I look at it from a person's point of view and look at that how technology has affected healthcare, that's what I was trying to look through, that what should I talk to all of you in today morning. And that's how I prepared a very simple presentation that what happens from a person's point of view and how do we utilize technology, or how technology today is actually changing the way we are managing healthcare or hospitals and healthcare of a person. So, a patient's journey, let's take the hospital first, the acute care, because there I think that things have changed massively. You have also seen that how things have happened during COVID, when we didn't know what was coming. And we did so much of technology in different ways to make sure that the situation is averted. So if you look at a patient journey, you all know that outpatient department, when you go to an outpatient department or hospital chamber or private doctor's chambers at their clinics, you have different processes. Each of this process, actually, we have started using technology in different ways. To me, the future of healthcare means that all of us have to look at it how we are doing our health today, how we are delivering healthcare today. If we think that we are at some stage, then to me, the next stages which have happened to the others is also, for me, it's the future. So I would like you all to actually adopt to technology as much as possible from wherever the status that you are. Even for my own hospital, I think we also are on technology adoption. We are far off than what the hospitals that I have worked before. I have many hospitals, worked with many hospitals in this city and the region, and so probably they are advanced in healthcare technology in many ways. But in my hospital, I have not yet. So to me, those hospitals and the advanced HISs or the technologies that they're using are actually, to me, a future. So that's what future is to me today. But the future of healthcare can be absolutely, unpredictable. You don't know what. It's huge. It can be many, many things which Arnab was actually mentioning. How you use blockchain or artificial intelligence and go wherever you want to go. So that's evolving and happening. So we will keep in touch with that also as the future. But today's future of healthcare, which I'm talking, is right on the ground level where we are delivering health. And if possible, we can look at each of our organizations wherever we are working. So booking appointments, pay bills, e-prescription, diagnostic reports, IP stay, these are all kinds of areas where you actually can use technology to make it a better experience, better delivery, and better care. Because whatever we are doing, we say that future health systems will have to be accessible, scalable, and equitable, while helping to preserve the health of the planet. So that kind of overview with which we will deliver care and use technology. So OP visits, chatbots in healthcare, you have heard about all this. I'm just kind of moving through. We do so many types of messaging. Information to us is very vital. So how we are passing on information to the other person, we use chatbots, we use cloud computing for doing the analyzing and organizing a patient's data. It's very important for us, for our decision making, for our functions. OP visits, we use blockchain as, to establish the database. When you gather data on a blockchain, the information you enter and all your personal data stays with you rather than being kept on servers, which is operated by an application. So we know the advantages of using blockchain. Then artificial intelligence, he was talking about so many automated alerts, identifying high-risk individuals, provide customized dose, all these customized dose, whatever dose you need for one particular person in medicine can be given by artificial intelligence. You have seen so many things happening. So IP stays in smart, say for example, I'll just give you a little example on how do you do smart linen management. We have in our hospital in Woodlands, every piece of linen that we use, be it patients, overalls or surgical linen or anything and everything, has got a linen RFID. It's tagged. So whenever the linen is moving, you are actually been able to see in the software that what is happening. So your linen management becomes guided by the linen RFID system. So that's using technology. And I don't think any hospital in the whole country have done linen RFID. It's been done I've seen it in Singapore, I've seen in US, they're using, but they're, that's the kind of using technology you can use to manage today's hospitals. So even hospitals like, I've seen people are also being tagged. So you have sensors all around the hospital on your terrace, on the roof, and then you have also tracks below. So you can actually move the trolleys which can actually move on a track and without any people, or you can also be tracked in different ways, be it material or linen or medicine or anything, because these are all moved inside the hospital in a very, very, very large number of movements do happen. The transports happen inside the hospital. So asset management system, huge number of assets which we have. Then your medical records. Arnav did touch about the medical records. It's like huge. So today we are putting everything he records in the cloud, using the cloud and putting it. And also by law you have to also keep the hard copy bedded tickets inside the hospital through a very smart medical record management system. Very smart, where you're picking up the right file and using it for the patient's care. Because as a patient, I'm telling you, as a patient, I can be many instances of going to a doctor, or it can be once or twice inpatient admission, and also you can need home care, and you have to be well. So wellness also comes into the picture. So that's all that can be done using technology in a far, far smarter manner. So, warehouse automation, smart cabinet system, Kanban is another process which is used by the technologies to reduce the idle time in process. In hospital management, time is like it's something which talks about care. So if you do say for example, time is everything for our quality of care. Say for example, I'll tell you, a patient with a heart pain come to the emergency, and you know that patient has to be actually done an angioplasty or put into cath lab. So there is a time that within 40 minutes you need to put the patient to the cath lab for a stenting or looking after the patient. So this timeline is actually a timeline. So if there's any delay in that 40 minutes, you are actually delaying in care, and some of your heart muscles will be damaged. So we need to be delays in timelines in everything in the hospital processes is very vital. So that's there. So we use Kanban to use technology and deliver care. IPs, the smart dispensing pharmacy, e-pharmacy, 3D drug printing, in nanomedicines, all these are coming into some hospitals are actually using them. IP stays with air disinfection solutions, different kind of surface disinfection, air disinfection solutions. Then your robots. The kind of robots that are being used in hospitals today are mind-boggling. Not only the surgical robot, who actually replaces a surgeon hand and docks into the patient's body and does the surgery. Robotic hands, that has happened years back. I bought the first surgical robot almost 15 years back in Apollo, which Rana operates now, Rana manages now. Those are the surgical hands used to do this. Till today does the surgery for the patient, and the doctor is actually sitting, the surgeon is in a console running those surgical robotic hands. Have you seen any surgery which is done by the surgical robots? It's mind-boggling how fast, how accurate, how smart they can do it. When you do eyes, if you compare it with a laparoscope, it's about 4 or 5 magnified size you see through laparoscope, and for a robot it will be like 15 times magnified. So it's like mind-boggling. So today we have disinfection robots, we have rehab robots, we have companion robots, we have medical transport robots, social robots who goes and talks, pharmacy automation robots, cyber knife robots, so many types. In discharge process also, e-billing, e-prescription, digital health tracker, in e-prescription, e-billing, these are all we kind of automate during discharge process. In home, again, digital health records, telemedicine, teleconsultation facilities, these are what are happening now. Telenursing, all this is practically happening. Teleradiology, e-ICUs is something which is again not been taken up by many hospitals, but is a very large area which we can, because in our country there are metro cities where we run the ICUs, and distant, the tier 2 cities and tier 3 cities, there are many things which are not there. So e-ICUs is very important to connect to the far and the far cities and towns and cities, and you connect and train from, because you have the lack of trained people here. So you are managing your care smartly, and you are also giving care to those areas. And this is EICU is again we are talking about for a long time, but it's not yet been fully done. We have to still do a lot much more. So we will need the biomedical companies like Philips, etc., to come forward and do this more easily and more cost-friendly way, because it's still very expensive. I was doing the EICU concepts few days back, but it was very, very tough, even now. Training is something which is very vital, and we use technology a lot, because in every aspect in hospitals and acute care, you need very trained professionals, be it a housekeeping boy who's not really housekeeping but actually disinfecting, to a nurse and technicians and doctors and everybody. So we kind of do retrain, re-educate, because things are new, new things are coming up, and people are not getting better. So we keep doing a lot of training and retraining and re-educating in the hospitals today. So for those, we use technology tools. I'll move ahead. There are a lot of challenges, as you know. Cost is one. Internet unavailability, I think we have moved a lot from there. Lack of infrastructure, unawareness, shortage of trained manpower, all these are continue to be. These are the things which are talking for last 2 decades. It still continue to be challenges, and we still have to do more on this. Government is doing a lot of initiatives, many things we don't know. A lot of digital work is happening from the government point of view, because when you look at the person, when I talked about the person in hospital home, it is a person perspective, but what is happening in the community is also very vital, and that community responsibility government has taken, and they're actually doing a whole lot of activities which many of us don't know. So I would request all of you to know what is happening from the government point of view, and actually take responsibilities there. Many, when I was just writing down, there are about 10-15 initiatives happening, and those needs to be worked on. And I think that's how I will close my year today. I just wanted to give you an idea that everybody has a role to play using technology and delivering better quality healthcare, and we must do that. Technology will help you to not only scale and equitable and accurate, but it's equitable and accurate, but it is also going to be standardized care, process-oriented care, faster care, and we must all adopt technology. And I know for a fact that all of our healthcare institutions are not really, or individuals and communities are not at the same level of leveraging technology. So my appeal to everyone would be to leverage technology, use it to deliver better care. Thank you all very much for your patient listening. Thank you.
Thank you, Dr. Basu. I would now request Mr. Rana Dasgupta, CEO, Eastern Region, Apollo Hospitals Group. He will talk about culture of excellence in hospitals. Sir, we will give you a lapel mic. Give me a minute. Would like to have a lapel mic? Take it.
It's good morning, dignitaries on the stage, dignitaries of the stage, my colleagues, friends from the media, and everyone else. See, I'm a person who's from the old school, and my background, actually, I'm a hotelier by profession who have come into hospitals. So I'm going to speak from my experience. And, I've been working for this is the 43rd year, out of which around 38 years is with hospitals. So I'm going to speak, what comes to my mind and from my experience. So the first thing is that, we talk about service excellence, but excellence will only come into a hospital, or there will be excellence in an organization when we bring about a culture of excellence. The culture, the environment in which we work is extremely important. And unless we bring in that sort of culture, you will never be able to achieve excellence in service. So it all starts with, when a person like a trainee or a person who has come for interview to your hospital or to your organization. Many a times we find that, a person who's come for an interview, you give him a particular time and he comes on time and he's waiting and waiting and waiting and, he comes in the morning and somewhere in the evening you take his interview for 10-15 minutes and ask him to go. And we don't even care whether he has had his lunch or, he's not even looked after. Many a time there are trainees who come to your hospital, they've trained for about 3 months and at the end of the training, they find that they have not learned anything because they've been used like, as runners running from one department to another and not really learning anything. So what happens when they go back to their organization? They go and give a bad impression about the institution, saying that, this is not the place to go because they don't know how to treat people well. So I think the first thing is that you need to respect everyone, even a trainee or a new person who's coming in for an interview. The second thing is, how do you select people? That becomes very, very important. So when we select people, the first thing that we look at is whether they know how to respect their seniors, whether they know how to respect their elders. So unless they know how to respect elders and their seniors, we really don't take them in. That is first. And the second is product knowledge. So selection becomes a very important thing. And also you need to select people who can grow with you. Because unless you select people who can grow with you, they become a liability later on, and they will not be motivated, and you will not have excellence. Now, if I speak about Apollo hospitals, Apollo Kolkata, we have a 744-bedded hospital, and it's a very, very busy hospital with almost an average of 86% occupancy with a huge load. Now, how do we manage this hospital? It is very important. You see, when you have to manage a hospital, many a times we look at the senior people. But I think the most important is your middle-level people. They need to be very strong, which means your supervisory level. Unless they are strong, and unless we train them, you can never have excellence. So we look at even the junior-most people, say your housekeeping boys. If you look at Apollo, when we started, we took in a lot of people from the area, and none of them have actually, they don't know about housekeeping. They have not been trained on housekeeping. They came in, they worked, they learned on the job, and many of them have been promoted as supervisors, and they don't even know how to use a computer. They may be class 4, class 5, class 6 pass, and that must be the case in many of the hospitals. So the first thing that we do is, we have taken this group of boys and started training them. We have invested money on training. These supervisors, in fact, we sent to catering college. We spoke to catering college and asked them to take a special, course for them. So they learned how to operate the computer. They learned how to speak English, English communication. And we started training these boys, and we created a pathway for them, a sort of a career path for even the junior-most persons. So that we changed their uniform. A person, if you need to have excellence, he must be proud of the uniform that he is wearing. So we started looking after them, and we created young leaders, very young leaders, and we believe now in leadership from below. So you may be having a large vertical, say you have a nursing vertical or an operation vertical, but we created smaller verticals within the larger verticals and put these young leaders in charge of these smaller verticals and gave them, they were allowed to take decisions. Even if it was the wrong decision, we corrected them, but they were allowed to take decisions, and they started learning how to be a leader. So now if you look at our hospital, we have created a very, very strong second line, a very strong third line, and even if the senior-most people in the hospital are not there, even with a full load of a full hospital, I'm quite sure that the hospital will run very smoothly. So I think why I'm saying this is, no matter what you speak about AI and digitalization and other things, it is the human pillar that is going to make all the difference. They must own the hospital. Each person must be owning the hospital. They must work, they must be motivated to work, and and they must be rewarded for good work that they are doing. And we should not wait for Diwali or for increments to come. The reward should be there and then. Reward doesn't mean only money. Even a pat on the back is some sort of a reward. So that is the human pillar that I'm talking about. Now, if you come to the clinical side, we have taken in a lot of young doctors, a lot of young talent, and we have a lot of senior doctors who are there. And I believe young talent coming in, the young doctors coming in, they come in with new ideas. They come in with they have learned how to use new technology, and the senior doctors who are there, they have such experience behind them. They have good clinical eye. So when they work together as a team, you have a very, very strong clinical team, I must say, and that is what is happening in our hospital. If you look at healthcare today, you can divide it into 5 segments. One is predictive health. Predictive health is when we talk about genomics. Yesterday we just opened our Institute of Genomics, formally opened our Institute of Genomics in Kolkata, where doctors are now looking at precision care. Earlier it was, we spoke about standardized care. Now, standardized care is, of course, is important, but now from standardized care, I think we are going to personalized care. And for that, I think, study of genomics, studying of genes, I'm not a doctor, but, studying of genes, whether, there is someone, a young person who's born with some sort of a gene which is a bad gene, and how to correct that. And predictive health becomes extremely important. I must give a small example. There was a young boy, a young child actually, he had come to our hospital and he had diabetes, juvenile diabetes, and he was getting almost 100 units of insulin every day, but they could not control his diabetes. And ultimately, through genomic study, they realized that there was some problem with some gene, and it was vitamin D actually which was given to him. And now that boy is doing well, and he has recovered. So you see, this is all about genomic study and genes. So one is predictive health. The other, of course, is preventive health. So that is extremely important that, we ask people to go in for health checkups, and we talk about pro health, where we are using artificial intelligence, to actually design the healthcare package for every individual. Preventive health is important, and of course then healthcare in the hospital. And then we talk about connected health. So ma'am was talking about EICU and other things. So we already have, we have connected to, we are almost 8 to 10 hospitals in the districts, in Patna, Chhattisgarh and other places, where our clinicians from our hospital is being able to monitor patients who are there in the critical care of those smaller hospitals who do not have that sort of an infrastructure, and helping them to take decisions on critical decisions on patients who are very sick. And then we have, so that is what we call connected care. And then of course we have home care, where now, you can set up a hospital at home. Healthcare has really changed. And previously it was, the change used to come gradually, but now change comes overnight. The other thing that I want to speak about, which is very important, that, if you have to run a good hospital, I think you need to put the patient in front and revenue will follow. It should not be that you put revenue in front and then, look at the patients. So that is extremely important. Now, some of you must be thinking that, Apollo is expensive. So how am I speaking about all this? So I will give you two examples about putting patients first. The first example is, we had a patient in our hospital, a young boy of 37 years old. And one day, while going through Facebook, we have a Apollo blog in the Facebook. I realized that there was a patient who was 37 years old, admitted in our hospital in critical care, in a very, very critical condition. And the father actually had appealed through Facebook to his friends to donate money for the treatment of his son, saying that he is very critical, I don't have the money, the bill is already more than the insurance that I have. And if I shift the patient from here, which I will have to shift if I don't have the money, the patient is not going to, my son will not survive. So looking at this, I asked my team to track this patient. And then we found that this was a 37-year-old boy who had a heart attack at home. And the doctor thought it was some sort of a gastric problem, the family doctor. And he was being treated at home for 4 to 5 days. But then he started deteriorating and, he had bilateral pneumonia. His heart was in a bad condition. And his kidney was affected. And when he came to our emergency, they could hardly find his pulse. He was very, very sick. And he had to be immediately put on a ventilator. And he was admitted under a pulmonologist and a critical care specialist. And then when I spoke to the doctor, they said that, his prognosis is extremely bad. But since he's 37 years old, we are trying our best to see how we can make him survive. But they also told me that the patient's father has requested, because he wanted to shift the patient to a government hospital. He didn't have the money. So then I called for the father. So when the father came to my office, he was a retired person from a very middle-class family. And when he came to me, he was literally shivering and sweating because he thought I'd called him because he had a huge amount of outstanding. So I asked him to sit and, I told him that, look, you are not going to shift your son anywhere. Your son will be treated here. And whatever you are able to pay, you pay. The rest of the money we will take care of. You don't concentrate on, don't think about finance, just concentrate on your patient. And, he started crying. And it was, I felt, I also became emotional actually. And then, about 15, 20 days later, I heard that the boy was off the ventilator, he was improving. And then, his father came to me once again and told me that, my son is going to get discharged tomorrow. And he told me that, look, he had a 3 lakhs insurance and there was some sort of a top-up which also has come. And there are 4 lakhs of rupees which came in as a donation from my friends. And, I have almost covered the bill. So I told him that this 4 lakhs that you have, you keep it with you. Because once you go home, your son will require further treatment, and he was a retired man. And I said, this 4 lakhs you keep with you. Whatever has come from the insurance, you pay and take your son home. But he refused to do that. And and at the end of the day, we found that he actually paid his bill. He paid that 4 lakhs, and more or less he had paid the bill. But the lesson that I have learned is that that boy is now back to work. Every time he comes to our hospital, both the parents and the boy come and meets the doctors, the nurses who have treated him. He comes to my office. And see, he has become an Apollo patient for life. An Apollo member. He's become a member of the Apollo family. And what better branding can be done, what better branding than this? So this is the first example I'm talking about. The second example I want to give is, we were actually, we had traveled to Chennai to have a meeting with our promoters, and my CFO and myself, we were coming back by the evening flight. So we were sitting in the first row, CFO was sitting in 1D, I was sitting on 1C, A and B was empty. So as the Indigo flight took off, the air hostess came to me and requested me if I wanted to sit near the window. I said that I prefer an aisle seat. So he said there's this young gentleman at the back, who's having a severe pain and he's unable to sit there. Could we put him in the front row because there's more of leg space here? I said, please go ahead. So I found that there was a young man, he was around 37, 38 years old, and he was in terrible pain, I could make out, because, his face, he was sweating, and he was very, very uncomfortable. And, throughout the flight, he was standing, moving on one side, he couldn't even put on his belt. And then I asked him that, what has happened to you? So he said that, I have a severe backache, which I'm having for the last 4-5 years. And I've been going to Vellore for treatment. And in between, it had improved, but now it has become worse. And he says that, I passed out. He's from Bangladesh. He's from Chittagong. He says, I passed out from Dhaka University, and I was doing a very good job, and now I've lost my job because of this back. And I've run out of finance. I don't have any money left. And I just had the fare to fly from Kolkata to Chittagong. And I don't know how I'm going to, how I'm going to survive, because I don't have any money and I can't work anywhere. So, it was pretty, I felt pretty bad. And so when the flight landed in Calcutta, I gave him a card of mine and asked him that, why don't you come to Apollo Kolkata, because you're staying tonight in Shialda. Why don't you come over tomorrow? So he told me, look, sir, I don't have the money and I can't afford. So I said, you come, we'll have a look. So he came over the next day, and we asked one of our spine surgeons to have a look at him. We requested him not to take the fees. And then they said that he had to do a number of tests. So I said, go ahead, please. So they did the tests, and then he said that he needed an operation on his, he had to be operated on, and said that he would require about 6 to 7 days to recover. So we asked him to go ahead. And today that boy is back in Chittagong, and he's joined back work. He's still in touch with us. And I think he's become our ambassador in Chittagong. And again, I'm saying that, I think that's the best form of branding that you can have. So why I'm saying this is, we are expensive, but we are flexible. That is extremely important. And you need to put the patient in front. Revenue will automatically come. You see, we have a full hospital today. We don't have to market, to get patients into our hospital. We don't pay any sort of referral fees or money or anything. Patients walk into our hospital. But I think that human face is very necessary. And you need to be flexible. We have told our staff that if there's a patient who comes to your hospital and is admitted in your hospital, and midway through, if he falls short of money, please don't allow him to go to another hospital. The treatment will be completed here. We will absorb whatever loss is there. So I think that sort of mindset is very, very important, not only for us, for the doctors, and even staff down the line. So this, I thought, was very, very important. If you need to bring in excellence into your hospital and bring in a culture which will bring in excellence. I think that's all I've got to say. AI and other things, of course, we are utilizing, and we are very lucky to have a group of almost 72 hospitals. So best practices are taken and are used everywhere. But I think the other thing is, as hospital administrators, we need to look at how we can make things simple. You see, if you, and it should be, we should be patient-centered. You see, and make things as simple as possible. We should not make things complicated. That is important. And let me also tell you, the best sort of suggestions will come from your staff who are working in various departments. You know, and we sometimes we just randomly call staff from various departments, even from telephone operations. I think that is such an important department, no one even looks at them. But you know, they are your first responders. So, you know, we call them and speak to them and ask them, you know, tell us how we can improve. And they are the people who actually give you the best advice. Thank you very much.
As it was mentioned, PwC is our knowledge partner, and they have prepared a thought paper on understanding the impact of Gen AI on Indian healthcare ecosystem. This has been the tradition. Every year we release a thought paper, prepared by PwC. So I would request Mr. Shayantan Chatterjee, Executive Director, PwC, to please make a presentation on the components of the thought paper and take us through it. Thank you.
The deck. Hi, good morning, everyone. It's always a pleasure and honor to be back at the chamber. And as was mentioned, so it's our 7th year of association, but doesn't feel so. We feel it still to be a young association relationship, and where we learn and we try to contribute, I would say, our 2 cents in this journey about where we enable healthcare, as we say, using digital as a lever. Thank you. So what we have done this year, being the theme, and as was mentioned by the panelists before, and I think the theme as well. So when we talk about what is really, I won't even call it disrupting, it's not a present continuous, something which has become a simple past, is the entire thing about AI, which is artificial intelligence, and the new, I would say, focus on it as generative AI. So I'm sure that all of us in the fraternity, in this room, and as industry stakeholders would have heard about it, have worked on it, I would say also. It's not something which is still in the works. and most importantly have found that what is the context that we would like it to be using in our day-to-day operations, with the ultimate theme that how do I deliver better patient care. That's the thing. So as part of this year's focus area, we have come up with a thought paper which is around generative AI in the Indian healthcare context. And I'll use the word Indian slash if I can use the word Bharat as well, with no political affiliation. Because it's very important to understand that what is the connotation in Indian context, which is unlike maybe what happens in a Western world. Obviously, there are learnings from there, but very important that what works in our society, in our care delivery model, with all the construct that we have from the payer and all some of the government scheme which has been there, what Arnav mentioned about ABDM, about any visual health standard, so much happening. So just like, again, a double click, I don't need to really preach to an audience which I'm sure is well aware and is, I would say, learn about what is generative AI. We are looking at generative AI being just an algorithm, to very simple as a tool, as a mechanism, as a software, whatever is the term that you may use, which uses data at the heart of it to provide insights, to provide content. Now that content, whether it's visual, textual, code, is far and foremost. The most important thing is that how are we harnessing that in the right manner to provide some of the critical aspects which help us in analyzing and helps delivering better care. So what it helps from a, I would say, healthcare point of view in terms of generating some of the synthetic medical images, wonderful of some of them which are very insightful being worked on. Creating what we may call, in fact, what we were just speaking about, that how do we have some of these personalized treatment plan? How do we have something which is very specific to individuals, patients we are talking about? Something which takes into cognizance the exact nuance of an individual body for that matter. Helping identify some of the, I would say, potential epidemic pandemic cases. And again, these are big, I would say, claims that we're making, but Gen AI has the potential and has to be basically working towards that. And we all know how we suffered during the pandemic. Then some of the things which really, I would say, suffers in terms of the basic operation from a documentation, the clinical care I was given, all of that. And the last but not the least, the entire thing around R&D. Now, if all of these things is being spoken about, generative AI has a play around it. And what we have tried to do is, like, again, we're just giving a glimpse. Sorry, the font is a bit small. But we wanted to give a glimpse that right from research and development, which is at the heart of any, I would say, budding clinical practice and industry in India, right from in terms of how do we look to define some of those patient and care management, the care pathways we are talking about, the robust care plans, the patient matching with regards to basically saying that which is the most appropriate provider, how do we basically assign that, and what is the most optimum care that can be given for a particular patient, considering his or her medical history that we are talking about. And in that, we have a very big enabler, which is the Ayushman Bharat Digital Mission. I'm sure all of you would have heard about it. And the entire concept of an UHI, which is a unified health interface. And that's a journey that we have taken as India. We've started, it's like a journey that has started, where each of us are working towards a scenario where for 1.4 billion Indians, there will be a longitudinal health history of all the health episodes that any person would have gone right from his birth. Whether it's a vaccine given, whether it's a drug administered, whether it's a test being done, the entire gamut about it. Think about it, the whole power of it actually becoming operational. That's a journey which has already started, and all of us are part of it. Then the entire thing around clinical documentation coding, something which is very operational, but really, I would say, is at the heart of it. On the right-hand side are some of the things in terms of real-time health monitoring, the medication management, digital diagnosis, things which you see is like what really impacts the patient and the caregivers on a day-to-day basis. So we are talking about all these aspects where Gen AI has specific use cases. We have, if you read our paper, we have basically highlighted some of them, and which are not just being will be worked out in the future, but are being worked in the current scheme of things. And there are various industry bodies, providers, health startups. It's literally a bustling, I would say, activity that's happening. And the entire thing, which is being pinned by what I called as the R&D and the drug discovery. So there's a lot of work happening there, where the real power of data analysis is being basically harnessed to work on that. Again, we are just giving you a glimpse, and all the things that we are talking about is something which is happening here. Obviously, as I've said, we will take inspiration from other geographies, but we are talking about some things which are happening. So right now, as we speak, there's a very interesting part that we are basically involved is in terms of the entire patient care and the entire how do we basically map the journeys. Similarly, we're working very closely with another aspect on the drug discovery part. So like what we are doing, there are numerous industry bodies and stakeholders who are working across the space for it. And I'm sure you will also find some of these sweet spots, and we'll be happy to basically, if you need, think of a discussion, we'll be happy to do that as well. Two things, just like what I mentioned about ABDM, why I keep on saying, because this is a reality which is right on our face about UHI, Unified Health Interface. Like the way UPI was a revolution 4 years, 5 years back, trust me, I'm not an Nostradamus to be speaking out here, but this is literally going to be the biggest game changer that we have seen in our generation, or what we'll see, where the entire health record transaction history for every 1 billion be on your fingertips with your consent. So what it does is basically, that's where one of the biggest use cases that is there for Bharat or India is that how does AI enable this vision and journey? There's a lot of things happening, right from the entire health records being passed, being basically then anonymized, because you don't want to be compromising on any of the specific, what is known as the unique health identifier. So you will not be able to identify that Sayanth and Chatterjee, but you will be able to identify a male in the age group, in this geography, with this chronic health habits. That's what you need from a anonymization. On the right hand side, I'll just briefly touch that whenever we're talking about something as, I would say, far reaching as Gen AI, it also needs into consideration the entire regulatory landscape. So DPDP, which is our Digital Personal Data Protection Act, which was passed last year by both houses of parliament, that's something which lays the rules and regulation and the guidelines of what needs to be done. So all the things that we are talking about needs to be responsible, needs to be safe, secure, and at the end of the day, with the consent of whose data is being shared. So all the things that we are talking about, because there's a big, I would say, anxiety in some cases that with all the things that we are talking about, the data exploding, is my personal data safe? So how and what is happening in this space? So fortunately, and we are, I think, all kudos to all the stakeholders who work towards making this a reality. So when we are talking about Gen AI in an Indian context, DPDP is literally the governing guardrails to ensure that we don't fall off and nothing of the I would say risk so-called that we perceive literally become a reality. At the same time, what we did as part of the paper, we also did I would say, outreach. We did primary surveys. We did a lot of industry consult with some of the stakeholders to understand that, hey, what does it mean for me in an Indian context? So all the things that you're talking about were some of the things that they say that how do we basically, so some of the, you may call it anxiety, challenges that they perceived, what I was mentioning about concerns about privacy, safety, discrimination, social, all the things that we talk about. But end of the day, everyone realized it's a game changer which is there in this sector for our good, for operational care betterment, for basically ensuring we have precise care delivery models, improving the experience that patients get, and most of important, being compliant with all the rules and regulations. So some of the things that we spoke about are I would say, exist in terms of challenges, but at the same time, we are fortunate that we have the guardrails and we have the, I would say, the vision that we need to be doing this in a much more responsive manner. So that's one thing that we, then when we gathered with the industry. So as PwC, so we do have what we call as a Gen AI healthcare transformation framework. Now what it does, if you see on the slides, again, the slide, the font may be small, so pardon for that. But right from how does it help you with your business decision analytics? How does it work on the data and information part? How does it work on the tech and infrastructure, which is literally your backbone of the thing that of the entire platform, to the governance and the cybersecurity aspects that I mentioned about, the organization culture, because it's a fundamental shift from where we are. And there's a big, I would say, myth that will it take my job? Will it make me redundant? Trust me, it's just going to empower you, and it's something which will make you that much more better in terms of the care that you deliver, the way you do that, and obviously the process integration. So we have ways and means how we work across each of the aspects. Again, just like I'm just giving you a brief, we have covered that in our paper as well, and we'll be very happy to, I would say, take follow-up discussions and conversations. But our intent is very clear. This is something that we as a fraternity, we are together on a journey, GenAI in healthcare, and I'm sure and I'm excited that as all of us in this chamber, and this chamber has always been at the forefront of promoting a lot of things which are progressive, I will be that. And each of you will have a part to play. Thank you. Thanks so much.
Thank you, Shantan. I would now request I will request Shantan to please stay back with us on the dais, and I would request Dr. Satyajit Bose, Chairperson Health Committee, the Bengal Chamber, and Chairman, the Mission Hospital, and Mr. Rajiv Savarwal, Partner, PwC, to please also join on the dais, and we'll have the formal release of the thought paper. And you know, you will find you know, standee at the registration desk with the name of the paper, and there's a QR at the bottom, and you can you can scan the QR and download the thought paper. And in any case, we will send you by email to all the registered participants and of course the speakers, the thought paper. But in any case, if you would like to download it today, you may please do it from the standee at the registration desk. And I would request Dr. Bose to please present a token of our appreciation to Dr. Rupali Basu and Mr. Rana Dasgupta before we move on to the next session. So the next presentation would be innovations in medical gas and devices to revolutionize patient safety and care. It would be presented by Mr. Anirban Sen, Head of Healthcare India, Linde India Limited. So I would request Mr. Sen to please join us on the dais.
this is a very good topic, and it's an honor for us to present such a good topic. And this is the future, like innovation in medical gases and devices for revolutionizing patient safety and care. And being an employee of Linde, we are always proud that we are ahead of any other gas organization related to safety of patient and gas supply. So to going to the first slide of it, so it is, we have heard like the senior people from the healthcare industry has just now spoken, and taking the cue from there, we can talk about the same point of IoT, Internet of all things. And the most exciting part here is about 127 new IoT devices getting connected every second globally. So it's huge. 1.1 trillion will be the market in 2026, 31 billion IoT devices by 2025. So internet is everywhere. We are connected to internet everywhere. And now from IoT, it has become IOMT, so Internet of all medical things. So in the daily life, like remote patient monitoring. So we know, we have our watches, like Apple has come up with a watch where a patient, if it is a patient is in distress, there will be alarms and the call will directly flow to a person whom the person wants to contact. It will come automatically, it will come to the function. So these kind of devices we are wearing, we are using, and we are also trying to get it connected to the devices, and which it can give us ideas, and we can give us, prescribe us what will be the future, how to move about. So this is about remote patient monitoring, transforming surgery. So this is also very critical. We have our smart surgery devices, where if you are removing a solid tumor, it's a cancerous patient, if you are going for an operation, you have, with the smart device, you can do ultrasound, you can know how deep you have to go. Where are the tissues, you can remove it proper, so the patients are much better and much more better for a longer period. So many kind of devices are coming in which are smart and which are handy and which is better for the patient, safety for the patient. We will also talking about the surgical trainings. So the traditional surgical trainings will not be there. It will be like augmented training where we can see, we can have the anatomy can be much better, much deeper. We are always talking about robotic surgery. So this is also something which is very important, which is coming in. So it's about technology everywhere. So everywhere here, and I am sure 99% of the people are using technology in some way at right this point of time. Smart hospitals which are coming up across the country, small hospitals which are coming in with all the datas are connected. So once you are there, you have every kind of reports there. Your patients are admitted, so you are getting sitting at home, you can have the patient details sitting at home, what is the SpO2 level, how it's functioning, how it's controlled, so what is doctors prescribing, what are the medicine, how the patient is today. So it is, you don't have to go to the hospital. So just to have a flavor how the things are moving in the healthcare industry on this IoT platform and IOMT platform. So a little bit of gases, which is the topic today and which always excites us coming from a gas industry, what Linde is doing. Few of our innovations we will showcase here. Like this is our black and white, all of you know the black and white, the traditional cylinders. Now we have LIV, which is Linde integrated valve cylinders. So these cylinders are already in India. In many hospitals across the country, we are providing these cylinders. In Calcutta, many of the hospitals are having these cylinders, and it is integrated. So you have like you have a mobile ventilating port, you have a ready connector, you have a flow meter automatically connected. It also has a shut-off valve, is very easy to open and off. So you don't need a group D staff, or you don't need anyone to come and connect the cylinder. You only need an SL cannula and put it to the patient. So this is the cylinder which we already have in our country. So, but we are doing R&D, we are going ahead, we are putting AI in cylinders, which we want to see. I want all of you to see this small video of it. No, hello, sound.
Have introduced the Live IQ Intelligent Oxygen Cylinder. It brings together digital technology and gas cylinder management. It calculates and displays the therapy time remaining on the cylinder. It shows the set flow rate. And if the cylinder is running low, it will alarm to let someone know. It seems simple, but Live IQ sets a new benchmark in mobile oxygen therapy. It provides peace of mind to healthcare professionals and ensures hospitals always get the most from their mobile gas cylinder.
So this is a cylinder with an AI. The cylinder will calculate according to the flow and the content of the cylinder, and it will show the patient how many minutes that patient can take oxygen. And it will also start giving alarms to the patients that the cylinder level, oxygen level is low, you need to change the cylinder. Another good thing which this cylinder has is that in our hospitals, we find that so many cylinders scattered across the hospitals, and we exactly don't know where are the cylinders, how they are kept, and what is the content of the cylinders. So these cylinders are all connected and with the software, and this can be monitored by the hospital, which floor, how many cylinders, what is the content of the gas. So you have a ready reckoner in your hospital and you can mobilize. You can find on the 3rd floor you have 10 cylinders, of which 9 are empty. So you have the idea, it's not the cylinder is there, gas is not there, so you can change it. So the whole control is in your hand. So this is the future cylinder, is the next gen cylinders which are coming in, which are under R&D for us, but we are in 2024, we are launching this cylinder. Another thing which is very close to us is this telemetry system for a liquid medical oxygen installation. So a liquid medical oxygen installation, in like for the last 3 decades, and I'm sure you have seen these liquid tanks in the hospitals. And this for the last 3 decades, we are having this telemetry system in our liquid tanks, and this gives data, live data, to our National Scheduling Center, which works 24/7. So we have data of each hospital where our tanks are installed, what is the level of the oxygen, what is the consumption pattern. If there is a sudden spike of consumption in the hospital, we immediately call up the hospital. Is there any leakage? Is there some kind of accident has happened that some emergency patients has come in? So, and this helps us. So there is no interconnection with the hospital. So understanding the level of the hospital oxygen, understanding the consumption pattern of the hospital, we schedule our delivery. So there is no manual intervention. Nobody from hospital has to call us and tell that we need oxygen. So during COVID, like Linde were supplying 1/3 of the oxygen demand, which is around 3,500 tons per day of oxygen. And 1/3 of the country is supplied by one company. So the government came to us and they asked that how you are doing. You're not a single hospital of yours is getting dry. So then we showed that we have this telemetry system for the last 3 decades, and we don't need anyone in the hospital, because that time hospitals were running at 25% manpower. So we don't need anybody from hospital to call up and tell us that what is the level. We know what is the level, what is the consumption pattern, what is the distance from the source to the hospital, how much time it will take. We schedule it. And That was adopted by government, and now PESO, who gives license for any liquid installation across the country, has made it mandatory that if you don't have a telemetry system in a liquid medical oxygen installation, you will not get a license. So this we are doing for the last 3 decades, but it came to light when the emergency has happened and we given a better service. So this is one thing which is a technology which we are using, and we are developing it further. One more equipment which we use in Europe, we are bringing it in India. So this is something also exciting.
Millions of patients need variating supplemental oxygen due to their ability to absorb oxygen through their lungs variates spontaneously. Studies show that incorrect oxygen dosing increases risk of hypoxia, straining the heart, and increasing the risk of blood clots. These conditions apply to several patients' conditions and diseases. Common practice is based on manually adjusting oxygen flow. For patients receiving long-term oxygen therapy, this can lead to months with suboptimal flow and large unnecessary SpO2 fluctuations. By combining the existing oxygen source with O2matic, we reverse the way of treating patients in need of long-term oxygen therapy. Instead of having a fixed oxygen flow, the healthcare provider defines an interval for oxygen flow and SpO2, so the flow can variate according to patients' needs. O2matic has already shown great results in hospital wards, where COPD and COVID-19 patients are receiving state-of-the-art oxygen treatment and feeling more safe. Relatives are feeling more secure, and healthcare staff are under less pressure. O2matic connectivity is an
So this is another equipment which controls the flow of oxygen as per the requirement of the patient. So you don't, nowadays we know one nurse is handling 10 patients, 15 patients, 20 patients in a critical care unit, and where the oxygen flow need to be changed as per the SpO2 level and other requirement of the patient. So this machine does not require any human intervention. You just set the record how much level of percentage of oxygen in the human body is required, and according to that it will take the flow requirement, it will change the flow as per the situation and the condition of the human body. So this is also a revolution which is already introduced in the Europe, and it's giving a very good result. So this is from my side, some few innovations which we are working with, which we are bringing in our country also for patient safety on the gas part. Thank you, and anybody has any question, you are free to ask. Which one? Automatic. It is around 4.5 lakhs. Okay, thank you.
I request Mr. Sen to please be on the dais once again, please. And I would also request Dr. Shottadip Bose, Chairperson of the Health Committee, the Bengal Chamber, to please present a memento on behalf of the Chamber. We will now move over to the next session. We will take 10 minutes break for the changeover. in geriatric care. I now request the moderator and panelists to please be on the dais. Mr. Anindo Das, Vice President, Marketing, Infinity Infotech Parks Limited. Request other panelists to please be on the dais. Ms. R.J. Arvind, Radio Presenter and Programming Consultant. Ms. Nilanjana Maulik, Secretary General, Alzheimer and Related Disorders Society, India, Calcutta Chapter. Ms. Shukarna Chakraborty, COO, Inving IQ. Ms. Gitanjali Sen, academician and author. Dr. Dhiresh Kumar Chaudhary, geriatrician and social activist and social entrepreneur and columnist and poet. I request Mr. Das to please take the session forward.
Okay. Thank you everybody for joining us today. And thank you Bengal Chamber for organizing health tech program for the last couple of years. And guys, I must say that Bengal Chamber, we are associated with number of chambers all, in Kolkata. But at least Bengal Chamber is the only chamber, I must say, who are, they are thinking about the elders. A round of applause to Bengal Chamber. Jode hattali hoye jak Bengal Chamber er jonno, at least they're thinking about the the elderly population and the elder care domain. So I myself, Anindo, I represent Infinity, and we have as a part of our social responsibility, we have set up something called Jagriti Dham very recently. It's not even 1 year old, for the holistic development of the elders of Kolkata. You're all invited someday. Please drop in. Before we start, we know the global population is, it's aging, and I have some, distinguished panelists with me who will share their insights. I think I have some data, 142 crore India's population, out of which 10.5% are the elderly population, and around 11% is in Bengal, and Kolkata around 20 lakhs. And these numbers are growing. I have chosen the panelists in such a way, each one are from different fields. I'll start with Gitanjali auntie. Gitanjali Sen, she's an author, she's an academician. And the reason for me to choose her, she has been part of Jagriti Dham community as well. She represents 80% of the senior citizen community, And before we share our point of view, it's very important that she sets the stage that what are the challenges an elderly faces in their day-to-day life. And from there, we can take it forward. I request Gitanjali auntie to start it. You can sit down and you can talk.
First of all, I have to thank Infinity Group, especially Anindo and his team, that I am here today on this platform and speaking from my experiences. The whole thing is a huge topic. Lot of challenges are there, no doubt. And as you know that when COVID took place, we were all in the house for some time. So we did some reading, singing, whoever likes whatever, to motivate oneself. And that way I came to know that United Nations has said, like Anindo said, about Kolkata. So many, we are in the elder persons population. Now, in the world, if we take, according to United Nations, it's going to touch 8.5 billion in 2030, which is just that scarce. But then no need to get scared, I feel. If the spirit is right, positive attitude towards life with positive happenings kept in mind that give us a little bit of happiness, all this makes a lot of difference, and we move ahead with the very sort of, we can say then, the old age becomes gold age. So if all of us are same, then it was much easier. But that's not going to be the case. Every two individuals will be different. So many individuals will find lot of differences. Now the whole topic is changing paradigm in geriatric care services. I'm very happy with what I get as rejuvenation, relaxation in Jagriti Dham when I go for, just for a day trip also, if it is possible. Why? Because my mother is 90, so she is the oldest. I am 65 plus. I am old. I handled my husband who had Parkinson's disease when he started at the age of 67. So with all this experience, all the teaching and all that has gone. It was a different ball game. Now I am handling and learning how to keep others happy. And that gives me a lot of satisfaction. So if you consider, taking from United Nations, if you go to WHO, they said, we've set up pillars. The health has to be taken care of. Elder care, people have to be well looked after. They must have lifelong learning, participation, which will give them security, sense of belonging. Now, again, there we have a lot of differences. So what I feel is that from my side, if I keep on complaining that I'm not getting enough, that won't help. That's a negative. So let's be positive. Again, I say that there are medicines all of us have to take after the age, certain age. Everyone has to take medicines. Then, so medication is there, mentation, something to do with the mental stimulation, physical, that is mobility, a lot of M's are coming in. Whatever is of utmost importance to the elder care, elder people, whatever group, old, older, oldest. Now then the variety comes from wherever you are getting the care from. Now care can be at home, in-house, or if a person is mobile and likes to go out, then go to a place where you spend a day or so with gardening or looking at flowers. So many things you can still do. If mental stimulation is there, we can continue for quite a number of years. Now, far away traveling, I will not suggest for all, but if it's possible, yes, it is. Because sometimes I've seen in my husband's case, airlines helped a lot. But we have to spend also a lot. Okay, fine, that's one part. Now, we can go to nearby places. Talk to positive people. Don't hurt the negative. Anybody who is depressed, maybe, you know, different natures can be there in front of us. Somebody happy, somebody sad. We won't hurt anyone, but at the end of the day, whoever gives me care, my motto is, my mantra is, I have to say thank you to that person. So gratitude gives me a lot of happiness. That, at the end of the day, gives me some number of hours of good sleep. And then there are so many other things, nutrition and all, they take care. Now, I have also noticed, after my first exposure with Jagriti Dham, that they have trained those people, I guess, this is my guesswork, that they have trained the compassionate and the patient people. They make good passionate elder care givers. So they need, again, some gratitude. And if this happy sort of chord is struck between the caregiving institutions and the people who are old, then the team will be working well and we'll be in the right direction. And Japan is another example we can take, because Japan, many people are over 100. Now, they are very good at mental work. They're doing their own work. When I went to Vietnam, I also saw everybody is working. Some old ladies, they were just making those bows, you know, white colored bread. and they would do that work that would give them some sort of positivity, you know. So this is something I admire. But yes, it can be suddenly I'm struck with something that hurts my mental ability. In that case, I will have to depend on them. But if from time to time the wiring connects, I will remember that I had thanked, and they also smile. Smile makes a lot of difference to me. So there are specialists who are here. They will talk more on all this. And this is what I have to say. I don't expect a lot, but change is the only constant thing in this world. So changing paradigm in geriatric care services, I support. Yes, of course, we need it.
Thank you, Gitanjali auntie. I think, couple of things, holistic development, engagement. And I think there's so much of fear in the society that, and the relevance of after 60, that it's over. Those changes are happening slowly, and I have, Dr. Dhiresh Chaudhary also, I'll bring him after some time. But I'll go straight to Nilanjana Maulik. She's working, she's the Secretary General of the Alzheimer's and the Related Disorders Society of India, Kolkata chapter. And she has been handling, specific elders with dementia and Alzheimer's, and I request Nilanjana Di to share your insights. And this is one field where the awareness is very, very poor, and we are not aware. And at home also, how do we know that, okay, now is the time for a specific, this kind of specialized care to start? Most of them, and especially in the rural areas also, how will they get to know about it, and the amount of awareness we need? And I think Arvind is here also. I'll bring him after you, that what role radio can play. So Nilanjana, your insights, please.
Thank you so much, Anindo, for this invitation to come and speak, and thank you, BCCI, for giving us an opportunity. As Anindo mentioned, that I represent the Alzheimer's and Related Disorders Society of India, the Calcutta chapter, and we have been in existence since 1999. And when I began the journey in Kolkata in 99, I had very, very few people wanting to know about dementia, Alzheimer's, because it was considered a normal part of aging. So if you age, it is very likely that you are going to forget and have other difficulties in life. So it took us a while to invite people and listen to what dementia is and how it is different from normal forgetfulness. So the journey has been almost 25 years. Our organization is completing 25 years this year. I think the awareness has definitely increased, but very, very much in the urban areas. If I go to the rural areas, I would still see a lot of people struggling with individuals who are living with dementia, various kinds of dementia. So awareness is the key, and as an organization, we raise awareness every month in different platforms all across Bengal. And in that awareness session, we inform people the warning signs of different types of the irreversible dementias. So there are, I'm not going to go into the details, but dementia does not necessarily mean that it's the irreversible types which we know as Alzheimer's or vascular dementia or, frontotemporal and Lewy body and so on. So it is very important that if we see certain brain impairment, we understand as family members and also the individual who is facing it to ask for help. Because আমরা সবাই খুব ভীষণভাবে অস্থির হয়ে পড়ি যখন আমার কোমরে ব্যথা হয়, হাঁটুর ব্যথা হয়, কিন্তু মাথার কোনো সমস্যা হলে আমরা খুব একটা হেল্প চাই না বা সেটাকে স্টিগমা অনেক আছে বলে আমরা লুকিয়ে রাখি। So I think awareness around brain health needs to be increased, and different modes of awareness delivery needs to be tried out. In urban areas, you could do it through lectures and interactive sessions, but when we go to the rural areas, which we have already started doing, it's through small skits, trying to give them real life examples. So awareness is definitely increasing. There are a lot of challenges in India in terms of dementia care. It's still not much understood, so the challenges are, of course, the stigma around it. So not many people would come out and say, my loved one is going through this. The second one is, of course, the poor diagnosis and the treatment. Many health professionals are still not, very aware of what dementia is and the different irreversible types. So we hear many families tell us that ডাক্তার কাছে গিয়েছিলাম কিন্তু ডাক্তারবাবু বলেছেন যে এটা তো স্বাভাবিক বয়স হচ্ছে ভুলে যাবে অসুবিধে হবে এটাকে নিয়ে চিন্তা করবেন না so I think the poor diagnosis and treatment is also causing a lot of delays in providing better care and the last but not the least is poor resources, human resources, and I think that is where we have to really work on to develop human resource caregivers. I personally am a caregiver. I started my journey 30 years back as a caregiver for people living with dementia, and I say that every day that one needs to really start from the ground level to understand what real care is, because these days the word care is loosely used. It actually does not target the actual care that the elderly person needs. If I, Gitanjali was, giving you a picture of the challenges, and of course, what I liked about her perspective was how to look forward to life. And I think that is one point we miss as experts, so-called experts. Now, these experts are all armchair experts. They are not somebody who is really talking to an elderly person. So I think hearing the voices of elderly people is very, very important. And that is where you start to design the services and activities after you hear their voices. So I think that's what I feel.
Great, very insightful, views, and I'll go to my friend Arvind. I'm very happy that he has come down. We keep hearing him every day morning, and he's the only one who who has been promoting retro musics in Kolkata, and he's a living encyclopedia of Kishore Kumar and R.D. Burman. But apart from his day-to-day profession, he has been associated with number of senior living homes, and he has been using radio as a platform in a much better way. Arvind, to you, what role radio can play, and second is what role music can play in the form of care for the elderly, and you have been involved in this kind of experiments. If you can share your insights.
Sure. Firstly, I think it's been a record time that a radio presenter like me has been away from this mic. I was waiting for the last 60 minutes. When would I get this mic to say something? So now that I have it, I have a smile on my face. Thank you so much, the Bengal Chamber. Thank you so much, Anindo, Jagriti Dam, and all the people present here. Firstly, can we have a huge round of applause for Gitanjali auntie? Everyone, a big, huge round of applause. And I'll tell you why. Because I was sitting right next to her. She was making these little points about how she has to say and what she has to say. And I was amazed that she did not even take out the paper a single time. When she was talking, what she was talking. And taking it from Nilanjana Di, she mentioned the words caregiver. I'll not stretch it much, Anindo, but with your permission, I think we're all made up of stories. How many of you have elderly people in the house? Raise your hands. In-laws, parents. Have you heard this one line quite a lot? Tui amake bolish na amake ki korte hobe. Yes or no? Right? That's the first thing that I realized as a caregiver. I have parents back home. When my mother was diagnosed with cervical cancer, I had an experience that has given me a lot of life lessons on how to take care of elderly people. I think one of the first things that we should realize is the form of communication jeta amra elderly people der sathe kori, that keeps changing from time to time. When you're 10 years, you have a different form of communication. When you're 20, আপনার একটা আলাদা communication থাকে. When you become 40, you have a different form of communication. Sometimes elderly people take that line, when you're taking care of them, when you don't want them to go somewhere, they feel you're intruding into their personal space. They feel you're trying to control them. So one of the first things that I realized as a caregiver myself is that line has to be bridged. যেখানে তুমি communicate করতে পারো যে মা বাবা, I'm not trying to hurt you, I'm just trying to do it for your own good. And them also, they realize it that you're doing it for their own good. When my mother was diagnosed with cervical cancer, one of the first things that I did was I sat down with her and I said, এই ক্যান্সারটাকে ডিফিট করার জন্য কি কি দরকার আছে তোমার? Discipline, diet, nutrition, finance. Write down all the points that you would need to defeat this cancer. And then I told her that the cancer is more of a friend to you. It's not your enemy. It's getting you to teach and learn all these lovely qualities which you wouldn't have learned if you wouldn't have been diagnosed with cancer in the first place. I'll tell you a small story. Amar ma jokhon hospital e chilo, I remember I looked at it from her eyes and her perspective. You know, elderly people think of the world in a very slow way, and there are administrators here, there are doctors here. I would request each one of you to get the operations in the hospital a little slower, you know, for them to understand what's happening around them, because they look at the world like that. They don't look at the world, je ekhoni korun, eta nin, eta chole jan. The caregiver who's coming inside, tar jonno hoyto 10টা patient ache, but for the patient, that caregiver is the only person who's coming. So that process needs to slow down. I think we underestimate the importance of spirituality. This is my third lesson. I think it's one of the most key areas that's been unexplored by anyone. You know, when I told my mother this, and I'm saying this on the dais, and this is probably the first time, I said, ki hobe? Maximum mara jabe? You'll die. At the end of the day, aaj na hole kal, everyone has to go. So why don't we go with a little smile and try to see what are the things that we could actually correct in our everyday lives? Let's go with gratitude. Let's go with happiness. Let us find that, and that's why definition and acceptance has to come. Why me? Amar keno holo? Amar cancer ho uchit na? I should not have had Parkinson's. Why am I suffering? My son is abroad. My daughter is abroad. Elderly people do this quite a lot. And I think I'll also be doing this when I grow old, to be very honest. Mane bolata khub easy. Je theek hoye jao. But when your blood sugar and your sodium potassium levels are nice, you're talking to an elderly person, je mane bechara bed theke uthte parche na, it's very, very easy to give them an advice, but I think it's very difficult for them to absorb this also. So I think the bridge is understanding spirituality, understanding in terms of letting go of life, and understanding that everything happens for a reason. You will grow old, you will, need to have medicines. The most powerful man in the world, is no exception to this particular rule. Lastly, the importance of radio. I'm going to come back to this with a wonderful story to share. I think we can do little things in our everyday life that can, get the quality of life for elderly people to be a lot better. First is, I think we need to be a society that is not obsessed with growing young. Apni television ta dekhun, ei cream ta dile you grow 10 years younger. Apni newspaper ta bar korun, you use this particular cream, you go 20 years younger. So let's not be obsessed with the young. Let's be a little bit more obsessed with the elderly, knowing je aaj na hole kal we're going to be there in their shoes also. So treat that with a little smile. And one lesson for caregivers, don't get burnt out. It's something that I've realized. When I sharakhon na ami baba mar care rakhbo, ami movie dekhbo na, I will not meet my friends, I will not talk to people, I will not listen to music. Please listen to my radio station. I play enough Kishore Kumar and Kumar Shanu songs. Try and take out some time for yourself, because apni jodi nijeke na bhalo rakhte parben, আপনি অন্যদেরকে কোনোদিন ভালো রাখতে পারবেন না. This is one of the very key areas, for elderly care that I think most people don't realize. Take some time for yourself, fall in love, go and meet friends, and involve your parents in every step of the process so that you don't worry about what needs to be done. Lastly, Onindo, I think most institutions need to know this, especially, panelists like Nilanjana Di. Community radio plays a huge role. আপনি যদি rural areas এ কাজ করতে চান, community radios are a boon and a blessing by the government of India right now. It takes 6 months to procure a license. If you've been an NGO or an organization that's been in operation for more than 2 to 3 years, you can read it on the website. apply for community radio. There is an operational expense, but you can train health givers, caregivers, elderly people. Someone like Gitanjali could be a radio presenter, tomorrow. She could do a show on what it takes to live life, from her prism, her perspective. So you could easily do this. I'll be more than happy to help out and train radio presenters ki bhabe kotha bolte hoy. And I think radio or any other medium plays a huge important role in the larger scheme of things. But at the end of the day, একটা line যেটা মানে বলা হয়েছিল এই stage, and I'm going to hand it over to that, is change is inevitable. What we are talking about right now is something that we're going to be dealing with tomorrow. I heard a lot of AI from start to bottom today. AI will do this and AI will do that. But I can assure you 1001%, and please put this on camera long after, even if I'm gone, there is no robot that will compensate the lovely touch of your child coming and hugging you and saying, Ma, ami tomake bhalobashi, baba, ami tomake bhalobashi. Thank you so much for everything that you have taught me. This is how life has to be. So AI will help us, do that surgeries and everything. I think it's beyond AI that we find a heart that beats, a smile that is genuine, and lastly, courage and acceptance. That is our way forward with geriatric care. Thank you.
Great. জোরে হাততালি হয়ে যাক অরবিন্দের জন্য। থ্যাংক ইউ সো মাচ। We have a doctor, Dr. Chaudhary. He's one such doctor who has been handling elderly, elders for the last, I think, over a decade now. And let's hear from him. And another thing I specifically have, there's a fear, for small things we have to put an elder to a hospital, and we feel that okay, at home we are not ready. So home care, is also plays a very important role. And what are the changes you are seeing, and what you recommend to the elderly population from your insights? If you can share your views, please.
First of all, thank you, Bengal Chamber of Commerce and Industries, to invite me in this great panel discussion, and thanks to the moderator and other accomplished panelists. I am the core field worker of the geriatrics, and today's discussion is on the changing paradigm or paradigm shift of geriatric care. So whenever we are discussing about the geriatric care, when we use the term geriatrics, it is slightly different from the elderly care. Obviously, geriatric care is under the elderly care, but geriatrics means when the healthcare is associated, when we are emphasize on the healthcare sector. And after hearing the Gitanjali's madam, that vibrant and positive words, and the RJ and the Nilanjana madam, unfortunately, the large section of the elderly people are not like Gitanjali madam. So this is one very fact. And if we're discussing about the paradigm shift of the geriatric care, when geriatric care is involved, if আমরা যদি সমাজটাকে দেখি, তাহলে the first geriatric paradigm shift is রবিবার সূর্য advertisement. আমাদের যখন যৌবন বা কম বয়সে আমরা যে কোনো পেপারের যদি দেখতাম রবিবাসরীয় যে অ্যাডভার্টাইজমেন্টগুলো, তাতে ওল্ড এজ হোমের অ্যাডভার্টাইজমেন্ট থাকতো একটা ছোট্ট কর্নারে, আর আজকাল ওই ওল্ড এজ হোমের অ্যাডভার্টাইজমেন্ট হয় দুটো ফুল পেজ নিয়ে। অ্যান্ড ওই সময় একটা ইনহিবিশন ছিল, দ্য অ্যাডভার্টাইজমেন্ট অফ দ্য ওল্ড এজ হোম। এখন সেই ইনহিবিশন নেই, প্রাউডলি দে আর গিভিং দ্য অ্যাডভার্টাইজমেন্ট অফ ওল্ড এজ হোম। এটার মধ্যে কোনো কিছু রং নেই। এবং এই যে প্যারাডাইম শিফট, আমরা যদি একটু প্যারাডাইম শিফট নিয়ে কথা বলি, তাহলে another one paradigm shift is what? First of all, geriatrics is derived from the word geron. It is a Greek word. Actually, it is very much related with the word jora of the Ayurvedic. ভারতবর্ষ প্রথম এই জেরিয়াট্রিক্সের উদ্ভাবন দেখিয়ে দিয়ে গেছিল, কিন্তু somehow it is not flourish in our country. It was flourish in USA and UK, but aste aste in last one decade, geriatrics become the what aware field, not popular field. Even আমি যখন নিজেকে জেরিয়াট্রিশিয়ান বলি তখন অনেকেই একটা ভুরু কুচকে ইয়ে করে, এটা আবার কি জিনিস, এটা খায় না মাথায় দেয়। সো হোয়াট ইজ জেরিয়াট্রিশিয়ান? লাইক নীলাঞ্জনা ম্যাডাম যেটা বলছিলেন যে একটা সময় ডিমেনশিয়া, এটা একটা মানে পাগলের রোগ, এটা জাস্ট পাগল। সো এই যে শিফটটা হয়েছে, এই শিফটটা হয়েছে এখানে হোয়াট সর্ট অফ শিফট? অ্যানাদার শিফট ইজ দেয়ার ইজ এমফেসাইজ অন geriatric people, because our population of the geriatric people is now nearly 13 crores. A 13 crores population in India, just one country in the Europe is more than the 13 crores population, Russia. Only the 5 countries of Asia, it is more than the 13 crores population. So 13 crores population of elderly people in India, এটা একটা কিন্তু হিউজ পোটেনশিয়াল কাস্টমার ফর এভরি ফিল্ড, নট অনলি দ্য হেলথ কেয়ার, বাট এভরি ওয়ান ইজ টার্গেটিং দিস population. And if the 10% of the population is মানে affordable, এটা কিন্তু একটা হিউজ মার্কেট. So now all the sectors are targeting the geriatric population for their business. Number third, if another thing we are, home-based care is now uprising. Home-based care, and I am representing 2 organizations. One is the Geriatric Society of India, that the organization, national organization, engaged with the geriatric physician all over the India. I am fellow of that. And I am representing another organization, that is the Majbo. Majbo is the NGO that initiated home-based elderly healthcare support in 2007, when that sort of conception was not there. আমরা 2007-এ শুরু করেছি, যখন এই হোম-বেসড কেয়ার বলতে কোনো ধারণা সে অর্থে ছিল না। ইন দ্য ইস্টার্ন ইন্ডিয়া উই আর দ্য ফার্স্ট অর্গানাইজেশন, এবং আমরা তার জন্য রেকগনিশন পাই, সেগুলো আমরা এখানে বলার জিনিস নয়। বাট নাও দ্য হোম-বেসড কেয়ার ইজ পপুলার, এবং বিভিন্ন কোম্পানি ইন দ্য লাস্ট 5 to 6 ইয়ার্স দেখবেন অনেক কোম্পানি এসছে হোম বেস কেয়ারে। বাট হোম বেস কেয়ার, ওয়েন এভার হোম বেস কেয়ার, ইট ইজ নট অনলি দ্য কেয়ার অফ দ্য অড জব অর লাইক একটা বয়স্ক মানুষকে ব্যাংকে নিয়ে যাওয়া কি হসপিটালে নিয়ে যাওয়া। মেনি অফ দ্য অর্গানাইজেশনস তারা কিন্তু কি বলবো সচেতনভাবে হেলথ সেক্টরটাকে খুব একটা অ্যাড্রেস করে না। বাট দিস ইজ দ্য very much required sector in যেটা moderator বলছিলেন, যে geriatric people they are not willing to go hospital. And এই ট্রেন্ডটা কি হয়েছে এখন, যে হসপিটালে দেখবেন 70 to 80% beds are occupied by the geriatric population, যে কোনো জায়গায়। এবং এই যে geriatric people are not willing to go hospital, সেখানে হোম বেস কেয়ারের একটা প্রাধান্য এসছে। বাট নীলাঞ্জনা ম্যাডাম যেটা বলছিলেন যে কেয়ার গিভার্স, অরবিন্দের মতো কেয়ার গিভার, নিজের বাড়ির কেয়ার গিভার, সে তো আলাদা, কিন্তু আমাদের এই কলকাতার পপুলেশনে 27% অফ দ্য জেরিয়াট্রিক পিপল, আমার একটা স্টাডি আমি করেছি এবং সেটা আজতক এবং অন্যান্য জায়গাতেও হয়েছে, প্রচার হয়েছে। তো সেখানে মোর দেন 27% অফ দ্য এল্ডারলি পিপলস আর জাস্ট দুজন থাকেন, কোনো কেউ নেই। সেইখানে ইম্পর্টেন্স অফ দ্য কমিউনিটি লিভিং সেটা ডে বাই ডে ইনক্রিজ করছে, এবং যেটা জাগৃতি ধাম করছেন, ভেরি গুড এফর্ট। অ্যাফোর্ডেবল পিপলের জন্য অবশ্যই এটা আমি সবসময় রেকমেন্ড করব, দোজ অ্যাফোর্ডেবল পিপল, তারা কিন্তু এই ধরনের কমিউনিটি লিভিংয়ে যাওয়াটা কিন্তু শ্রেষ্ঠ পথ, বিকজ তাদের আর কোনো চিন্তা কিচ্ছু করতে হয় না, সবই কিন্তু আন্ডার ওয়ান রুফ। বাট আনফর্চুনেটলি অ্যাফোর্ডেবল পিপল কতটা, সেটা হচ্ছে যে একটা জেরিয়াট্রিক পপুলেশন আমাদের ইন্ডিয়াতে, সেখানে 10%-এরও লেস হচ্ছে অ্যাফোর্ডেবল পিপল। সো এনিওয়ার দ্য ডিসকাশন ইজ গোয়িং অন, we are not targeting the BPL sector of the elderly people. But elderly people to শুধু elder care does not mean it is only for the affluent society. আমার ব্যক্তিগত অভিজ্ঞতায় আমি একদম গ্রামে কাজ করেছি, সুন্দরবনে আমাদের জেরিয়াট্রিক ক্লিনিক চলে, ঝাড়গ্রাম জঙ্গলমহলে চলে, সেখানে যেমন আমার এক্সপোজার উইথ দ্য জেরিয়াট্রিক পিপল, রুরাল জেরিয়াট্রিক পিপল, আবার এক্সপোজার টু দ্য অ্যাফ্লুয়েন্ট সোসাইটি অফ দ্য কলকাতা, কোটিপতির সঙ্গেও আমি কাজ করি। ফলে সেই দুটো জায়গার এক্সপোজারের ভিত্তিতে বলা যায় দ্য প্যারাডাইম শিফট, হোয়াট এভার ইজ হ্যাপেন, ইট ইজ অনলি ফর দ্য অ্যাফ্লুয়েন্ট সোসাইটি অফ দ্য জেরিয়াট্রিক পিপল, নট ফর দ্য বিপিএল অর দ্য আন্ডার প্রিভিলেজ গ্রুপ। সেখানে বরঞ্চ ডিটেরিওরেশন হয়েছে জেরিয়াট্রিক কেয়ারে, no one is known about the geriatric care, no geriatric oriented physicians, doctors are there, no clinics are there. আমাদের ওখানে সুন্দরবনে কাজ বয়স্ক লোকরা দেখাতে আসে নদী পেরিয়ে 2 ঘন্টা 3 ঘন্টা 4 ঘন্টা নদী পেরিয়ে জাস্ট টু গেট দ্য ফ্রি মেডিসিনস। সো সেই জায়গায় প্যারাডাইম শিফট একটা বড় সেক্টর হয়েছে, ইট ইজ বাই টার্গেটিং দ্য অ্যাফ্লুয়েন্ট সোসাইটি। আপনার আরেকটা জিনিস, দ্য মিডিয়াস আর নাও plays their important role to promote the geriatric care, not only print media, electronic media, shop media তে এখন আস্তে আস্তে এটা আমাদের we are very much happy and pleased that এটা আস্তে আস্তে এই geriatric sector নিয়ে আলোচনা হচ্ছে, যেটা today's this is the example, true example of the paradigm shift of the geriatric care, and that sort of topic is there in the BCCI's health summit. And আমি খুব আনন্দিত যে just 1 decade back, in the 2014, BCCI organized same sort of one panel discussion, that old age care and geriatrics, and I was the moderator of that discussion. And সেখানে আমাদের legendary late Dr. Subroto Moitro, Dr. Rothin Chakrabortyর মতো অন্যান্যরা সবাই ছিলেন। তো BCCI is playing the very important role to promote the geriatrics. And the caregivers যে অ্যাসপেক্টটা বললেন, I am the task force member of the Healthcare Sector Skill Council of India, ইস্টার্ন জোনের। আমি সেখানে বারবার প্রমোট করছি যে একটা লার্জ সেকশন whoever is dependent on the caregivers, not by the family members, but যেটা বাজার চলতি আয়া বলি আমরা, they are not minimum trained. So সেইখানে due to that lack of training, due to that lack of orientation, how to behave, how to deal with the elderly people are suffering. তারা পয়সা দিতে প্রস্তুত, তাদের কাছে পয়সা আছে, but they don't have that sort of resource. We don't have that sort of resource, and unfortunately government was not eager to address. আমি এখানে কোনো গভর্নমেন্টকে আলাদা করে বলছি না, কিন্তু যে নিডসটা দরকার ছিল, মানে যে নিডস আছে তার তুলনায় যে সাপ্লাই অফ দ্য geriatric care animator or the caregivers সেটা নেই। নো ট্রেনিং ওয়াজ দেয়ার, নো ট্রেনিং ইজ ম্যান্ডেটরি। ফলে যেরকমভাবে পাচ্ছে জেরিয়াট্রিক কেয়ারে এখন ঢুকে যাচ্ছে। সো অ্যানাদার টার্গেট অফ দ্য জেরিয়াট্রিক গ্রুপ ইজ বাই দ্যাট পিপল, দোজ হু আর জাস্ট নো হাউ টু মানে গেট ইনকাম বাই নট প্রোভাইডিং এনি কোয়ালিটি সার্ভিস। সো এই জায়গাটাতেও কিন্তু আমাদেরকে অ্যাড্রেস করতে হবে if we like to think the positive paradigm shift. So this is very important, and obviously the specialized people of the geriatric section, that is the Alzheimer's patient, dementia patient, Parkinson patient. So in that sort of, and in the mental disorder, আমরা দেখছি যে শুধুমাত্র না জানার কারণে, অধৈর্যের কারণে, যেটা মিস্টার অরবিন্দ বলছিলেন যে কেয়ার গিভার বার্নআউট ইজ এ ভেরি ইম্পর্টেন্ট ইস্যু। কেয়ার গিভার বার্নআউটটাও কিন্তু আমাদের ভাবতে হবে, অ্যান্ড উই হ্যাভ টু চেঞ্জ আওয়ার মাইন্ড। কেয়ার গিভার্স মানে আয়া মানে কিন্তু নট মেড সার্ভেন্ট। আমরা সেই মাইন্ডে তাদেরকে নিচ্ছি বলেই তারাও কিন্তু সুযোগ পাচ্ছে। দে আর ভেরি মাচ ফ্যামিলিয়ার টু মেক এ টি, বাট নট টু বাথ দ্য এল্ডারলি পিপল। So that changing of mind is also very much important, and I think that in the discussion of the BCCI, it will promote this sort of very much urgent needs, and obviously message will be given to the authority to think more and more about the geriatric care. This paradigm shift is not coming spontaneously, but I must say it comes for the compulsion, because আমাদের এই এতটা বড় সেক্টর যদি আনপ্রোডাক্টিভ থাকে, নো সাস্টেনেবল ডেভেলপমেন্ট উইল বি দেয়ার। থ্যাংক ইউ ভেরি মাচ।
Thank you so much, Dr. Chaudhary, for your insights, and I must thank you. And he has been, promoting. He's a social activist also, and he's a very good poet also. And I'll meet you someday, and we should also discuss about the rise of the, the elder abuse which is going up. No one is talking about it. There is no policy in place. That can be a separate topic of discussion, but this is one topic which I thought that we should discuss. I'll end the session. I started with a lady. I'll end it with a lady. So Shukarna is here, and it's good. We keep seeing, the entrepreneurs who are male-dominated. At least we have an entrepreneur who is a female, and she has been solving some core problems in the care domain. Shukarna, specifically, what is the problem and how your organization is trying to solve it? If you can share with the audience.
Thank you so much, BCCI, for this opportunity. Thank you so much, BCCI, for the opportunity. Thank you, Jagriti Dham and Anindo.
Can you hear her voice?
Am I audible? Am I audible now?
Yes,
Yeah,
now I
thank you
think
so much. So thank you, BCCI. Wonderful opportunity. I love speaking on topics like this, very, very close to my heart. Thank you, Jagriti Dham, Anindo. I mean, again, I can go endlessly, but I know there's a time limit to it. I will, with the topic that we have in hand, the paradigm shift in geriatric care, let me start on a lighter note. Remember the song by Nochiketa on Vriddhashram and how blackened it was portrayed and how it was such a bad thing to fall back upon a support system for the elderly? Days have gone. I cannot agree more to what Mr. Chaudhary said on the ads which are coming now, which are kind of highlighting that there is no shame in falling back or exploring additional health. When Mr. Arvind said that, as primary caregivers to our family members, we are also juggling career, we are also juggling our personal lives. So there is absolutely a requirement in today's day and time to find resources, to find avenues where elderly people can find that solace, can find peers, can find comfort in living a life that is filled with dignity, because that is possibly the first thing that is taken away from, the sunset years, dignity. Apni kichu janen na, you don't know how to do it, let me do it. Possibly even a grandchild coming and grabbing the remote and saying, "Uff, tumi parcho na, let me show you." So the first thing that goes away when we're talking about sunset years is possibly dignity. And when it comes to, avenues or places like Jagriti Dham, retirement villages, care home, hospice care, or, home care, it's a fantastic landscape that we're talking about. Now, if I draw parallels from Europe, where we predominantly started working and we are now exploring into India as, the company that I represent, InvictIQ. Now, if I draw parallels from, let's say, UK, or a Denmark, or a Sweden, I know that, I might not be able to cut, copy, paste what they're following there, because fundamentally, traditionally, Indian community, Indian mindset is very different. We will still choose family members as our primary caregiver before we move on to something else. And precisely that is why we'll see that while care homes or retirement villages are quite a requirement abroad, here it is always a secondary choice, the primary choice being home care. Now, like again Mr. Chaudhary said, there's a plethora. Today, if you just Google, you'll not get an exact number of home care agencies that have cropped up in India. There's no number. But if you look around the paper, Google, there's pretty much every company who's assuring you of good care. Is there an assurance? No. Who's measuring this? Who's regulating it? Nobody. I'll not name, but bigger brands on discussion have said that, it's just our voice. Tomorrow we let out a paper ad saying we make it safer by 80%. People will take what we are saying because there's no data to prove. Now, data again is something that is very close to my heart. Now, what COVID did and what Mr. Ambani did with Jio, practically technology, wanted or unwanted, is in everybody's pocket right now. We are possibly the world's largest data consumer, the largest data producer. What can that data do for geriatric? Now, before even I say that, obviously this is health tech, I cannot leave behind AI, I cannot leave behind technology. That is what also our company represents. And before making it sound scary, like AI, for a sector of people who might not be very tech savvy, for whom technology might not always be the easiest thing to adapt, there are still so many stages where AI and technology can be inbuilt, right? So even before I go into IoT of things and rings and magic pillows and smart mattresses, what am I doing to enable my caregivers? Am I thinking of a product? Am I thinking of technology which will help their processes, which will help optimize their care delivery? Because I remember Mr. Rana in the morning said, that your employees deserve a pat on the back, not just on Diwali and Holi. Technology is that pat on the back, make it easy for them to deliver care. Because, you know, and I totally empathize with doctors, nurses. If you are day in, day out dealing with people who are unwell, on the harbinger of death, it's very easy for themselves to get impacted, right? How much can you watertight yourself to these emotions? So in that case, how am I using technology as an enabler, you know, to make my life easy, to make the processes optimized? I totally agree with what Mr. Arvind said. Nothing beats a hug. Nothing beats, you know, your child coming and saying and hugging you, or for that matter, even a carer's touch, you know, helping them walk, take a walk around the garden. So in that case, we can talk about technology endlessly, and even while I represent a company which is thoroughly all about data and technology, we know, at least in the care sector, technology will always be just an enabler. It can never, ever replace what human can do as carer. Now, before possibly I would stream into everything that everybody said, and I would say that at the end of the day, it is very, very crucial, because right now we are in a beautiful cusp, the whole elderly care sector in India. Now, first and foremost, possibly would be a small request, is not to club anything and everything to do with senior citizens into one bucket of geriatric care. The elderly care market, the elderly care segment is much bigger than just geriatric care. So what exactly we are doing, and like rightfully said, how can we think of processes, how can we think of products which helps us optimize, which helps us quality control, regulate? Because, you know, I can totally agree when anybody says, like Gitanjali auntie said, that I'm here, I'm taking care of my mom or, you know, my husband, but there are also similarly so many children who are abroad, whose parents are possibly taking help from one of these establishments. How do they get peace of mind? So that is where, you know, technology can be used. So my only, I'll possibly end it with that, that using technology, using AI, even before we think of using it on the end customers, obviously there'll always be a scope, but the processes which can be optimized to help the carers and make the whole caring sector more inclusive and a more interesting sector for people to come and work. Thank you so much.
Great. And, you know, I'm so happy that startups like her, at least coming back to Kolkata and trying to solve this major problem. And I think for that, please, you know, a round of applause to Shukarna. We'll move to the audiences. Any specific questions do you have or anything to share? Yes, I think we'll open it to the audience, please. If you can give the mic to her. Couple of questions, and then we can end the session and rush for lunch.
Hello. Namaste to all the panelists, and thank you for allowing me to ask and share my thoughts. Thank you to everyone to present here. I am Binsi from Antara Institute of Health Sciences, which is the academic wing of Antara Psychiatric Hospital. And like most of you have shared your insights from your respective fields, and have addressed the idea that there is a lack of trained caregivers, especially for persons dealing with mental health disorders and illnesses. So we have started with a caregiving course for those caregivers who are dealing with persons affected with dementia. So we have just started with a caregiving course, and one of the challenges that we see while working in the caregiving health sector, especially for the geriatric population, is lack of investment. Because the popular perception is that the geriatric population in the end may not be very productive form of investment. So how do we change that perception of this population being unproductive, and hence bring in more investment, whether it is from the government's angle or from private investors or sponsors?
Okay, I think Dr. Chaudhary can take this up.
First of all, thank you, Dr. Satyajit Bose, because so accomplished and persons in front of me. It's my privilege. So your question is, now the scenario is opposite. Now the companies, the hospital, the other industry, even the tourism industry, they are targeting the geriatric population. And geriatric population now, the potential customers of everything, even the gold. You have seen that the recent advertisement, now they are not giving your serial artists, rather they are giving the pictures of old couple. So everyone is targeting this, and your another one thing you have mentioned that Antara is giving the training, but training is if not mandatory, then we cannot address the problem. It should be mandatory training, mandatory certification for everyone, whoever is giving the geriatric care or the specialized care, and that should come from the government sector. I am requesting every time to the HSSC, Healthcare Sector Skill Council, to certify mandatory certification, but some problems are there. I would like to not mention. Another one thing, আপনি বলছিলেন যে আমি কিন্তু অ্যাডভার্টাইজমেন্টের বিরুদ্ধে নই, আমি আরো বললাম যে দিস ইজ দ্য পজিটিভ প্যারাডাইম শিফট দ্যাট অ্যাডভার্টাইজমেন্টটা হচ্ছে। আমাদের সময় একটা ছোট কর্নারে বৃদ্ধাশ্রমের অ্যাড চলতো, এখন রবিবাসরীয়তে 2 পাতা জুড়ে অ্যাডভার্টাইজমেন্ট হয়। বাট অ্যানাদার আপনি যেটা উল্লেখ করলেন যে ইজ ইট কোয়ালিটি ইজ মেনটেনিং, একটা এল্ডার কেয়ার হোম করলেই তো হলো না। আমি এমন কিছু এল্ডার কেয়ার হোম ভিজিট করেছি যেখানে কোনো রকম ডিগনিটি মেনটেন করা হয় না, ন্যূনতম ডিগনিটি। সো দিস রেগুলেশন ইজ ভেরি ইম্পর্টেন্ট। কে রেগুলেট করবে? এবং আপনি যেটা বললেন যে প্রত্যেকেই বলছে আমরা দ্য বেস্ট সুপিরিয়ার, তো হু উইল জাজ দ্য সুপিরিয়রিটি? এনি কোনো কিছু আছে? ইউএসএতে হোম বেস কেয়ার চালু করতে গেলে লাইসেন্স নিতে হয়, বাট ইন ইন্ডিয়া আমি অনেক ঘেটেছি, বিকজ আই এম হোম বেস কেয়ার সাপোর্টার, মানে যেখানে 2007-এ শুরু করেছি, নো সাচ সর্ট অফ সার্টিফিকেশন ইজ রিকোয়ার্ড। সো সার্টিফিকেশান এখানেও আনা দরকার। যারাই হেলথ কেয়ার সেক্টরে আসবে তাদের সার্টিফিকেশন রিকোয়ার্ড, তাদের অডিট করতে হবে এভরি ইয়ার। দেয়ার মাস্ট বি রেগুলেটরি বডি, যারা ভিজিট করবে দেখবে কি যারা যা কমিটমেন্ট করছে সেটা ফুলফিল হচ্ছে কি হচ্ছে না। সো দিস ইজ ইম্পর্টেন্ট। অ্যান্ড আপনি যেটা বললেন, আমি যেটা বললাম যে এখন কিন্তু প্রত্যেকেই টার্গেট করছে, বাট টার্গেটিং বিকজ 10% অফ দ্য এল্ডার পিপলও যদি আমাদের অ্যাফোর্ডেবল হয়, দ্যাট মিনস মোর দেন 1 crore। সেই 1 crore অফ দ্য এল্ডারলি পিপল ইন ইন্ডিয়া, এটা কিন্তু একটা হিউজ পোটেন্সিয়াল কাস্টমার। সো সিনারিও উল্টেছে। থ্যাংক ইউ।
Onindok, sorry.
Yeah, I forgot your name. Yeah. Well, see, I have just one thing to say, and I'll say this from an entertainment perspective, because I come from a line where there's constant battle between revenue and what I need to do. There is something that a sales team tells you to do and something that I really want to do idealistically on radio. So money is where the crowd is, and crowd is where the perception is. Till about a couple of years back, before a movie like Lagan released, you wouldn't even look at the story of a movie. You would just go because it's a star and you would like to enjoy, right? Why is it today that producers and directors are writing different scripts? Because they see a different audience which is ready for the kind of movies that they want to make. So I'll take this and compare this to what you want to do. 15 years back, if you would have asked me this question, I would have said, I mean, God is going to help you and let's see when the policies are going to change. You have something called the internet in your hands. You have something which is the mobile phone. While using it to the best possible effect, it's like a fire in a jungle. I can tell you this, if you light a spark, it could just explode. Once you have the numbers on your side, the guys who are taking the decisions at the policy level will notice you. The people who are going to invest money will notice you, because it all comes from the crowd. And it's very easy for you to connect to like-minded individuals, create groups, create communities and forums. I know it's not an overnight job, but someone has to do it. And I pray to God that you would be the first one to do it. And you and other people similarly need to come together. You know, get people like Onindo, get people like, Dr. Chaudhary. Bring together discussions like this. Use the internet to explode, amplify your cause. And I trust you that the health policy makers are going to take note of it and say, if there is a crowd which is interested in this, I'm going to put my money and energy into making a policy change right now.
I just wanted to also add another point. Of course, you need policy and you need certification. But what I find over the years, I have also been involved with the National Institute of Social Defense, where we have a caregiver program. It's the modules, the design of the modules that's a problem. So if you want a caregiver to be trained in dementia care, it cannot be just teaching them about dementia, the signs and symptoms, and the medical perspective. It has to be from the human perspective. And I think practical training, hands-on training, exposing them to what dementia is all about, not theoretically, but practically. And I think that what is missed in most of the modules. And our organization, we train 4 times a year. And what we have learned over the years is if you can change the modules, make it interesting for people to come and take it, you definitely wouldn't be disappointed, because over the years we have younger people, more and more younger people coming and wanting to be trained, because they do see a huge area where they can contribute. So I think designing modules is very important, how you are designing the modules. Thank you.
Thank you. I think
Anindo, I'll take a
yes,
minute.
Yes.
See, there's a huge, like what Jagriti Dham is doing right now, right? There are elite retirement villages and care homes which are coming up, okay? And in most cases, the parents who are taking these services, the children could be staying abroad. Now, abroad, they are very well familiar with a very regulated care sector, where there are regular audits every year, where even training is mandatory and so on and so forth. So I do not know, maybe just putting 2 and 2 together, if there are like-minded such organizations, they can always go ahead, avail such services, but like as Nilanjana ma'am said, they have to make sense for the people taking it, they have to make sense for obviously for the eventually end customers. But at the end of the day, if a care provider based in India can be in sync and say that, we are matching global standards, look, all our staff is trained, look, this is how we do audit every year. It's a match made in heaven. It's a matter of time, like Arvind said. More kudos to you, more power to you. Be the first one to start, but it's just a matter of time.
Thank you, and we can take other questions offline. We should end the session. We'll take it offline, ma'am. The time is over. Angana has already given the greens, the signal. Before we end, a small request. Let's take a vow, a small vow, that no elders in Kolkata should feel lonely. Ladies and gentlemen, that's a small vow if we can take and end this. And I request each of the panelists with me for their time. Thank you, Bengal Chamber. Over to you, Sharbani. Thank you.
Thank you, Mr. Das and the panelists for joining the session. Now we have a pleasant task to perform. I request Dr. Shotyajit Bose, Chairperson of the Health Committee and the Chairman, the Mission Hospital, Durgapur, to please join us to present the mementos to the moderator and the panelists. To R.J. Arvind. Ms. Nilanjana Maulik. To Ms. Sukanya Chakraborty. Ms. Gitanjali Sen. And to Dr. Dhiresh Kumar Chaudhary. Now I request Dr. Bose to present a memento to Mr. Anindo Das, the moderator of the panelist. I now request the moderator and all the panelists for a group photo session, please. Thank you for joining us. We will now move over to the next session. Innovations in Health and Biotechnologies Inculcating the Spirit. I request the panelist and the moderator to please be on the dais. Mr. Shayantan
Old
Chatterjee.
age needs a true friend indeed, who is ever ready to hold hands in every need. An assurance that can conquer all worries of loneliness, insecurity, and health. It's time now to open a new chapter of positivity. Let's bring back the hues of joy, compassion, and security back to those lives. Jagriti Dham always feels happy to drench in the colors of cheerfulness with your arrival in our family. We feel overjoyed to welcome you with open arms in our realm of eternal ecstasy, where you can start your day with yoga session amidst green and moments serene, and experience the lovely sight of your near ones dropping into your doorsteps. Give your closed ones a grand reception at the grand lobby of your new home. Ample light and wind here for everyone to refresh and unwind. Well-planned construction with wide corridors, ensuring hassle-free movement for all, always. The AC Lounge has the perfect setting to meet and greet your special guests. Enjoy all your 3 meals with the friendly fellow residents at our spacious dining hall. You can also savor the lovely food at the outdoor dining area, next to the greenery outside. You will love your delightful dish that comes fresh from the organic farming practiced within the premises. Go for a healthy walk at the backside lawn and cherish all your lovely experiences here. We will offer you super conveniences inside your bedroom with a bedside call button in any emergency. Days are sweet as a song from the balcony with greens and glory all along. Rooms are of 2 kinds, normal and special. But an attendant will always be there to give that extra special care. Special rooms have wide and seamless washrooms for the special ones with physical challenges. Every resident will be healthy and steady, as our in-house nurses are always ready. Special care for patients' smiles, and every document will be preserved in files. Our spacious lifts will always be at your service to take you places with ease. There will be no lonely evening, as your attendant will always be caring. Enjoy a lovely movie with your co-residents, or to talk to your children who are far inside our well-equipped AV room. There is also a gym of new age to challenge the worries of old age. Find peace in the meditation room and let your spirituality bloom. Jagriti Dham, bringing the happy hues back to your lives. Go for a spa at your leisure and relish those moments of pleasure. A great stock of books in our library will keep your soul busy and merry. Challenge your opponent in the cards room with your card skill at will. Let time fly in company of your fellow residents with some moments high. Memorable get-togethers in the multi-purpose room will let you cherish the lovely essence of community living. Healthy food maintains hygiene as we keep our kitchens neat and clean. see your prayers getting an answer at your second innings of life over here. Old age can never be a burden when you have a trusted one to hold your hand. Trust us when we promise.
Shantan, you can take it forward now.
Good afternoon, everyone. I know we have a very difficult session to manage. See, there are two difficult sessions always in a thing. One is which holds you between lunch, so we'll try to be as engaging as possible. So welcome once again to all the, I would say, participants in today's session. So we have, I would say, a very diverse panel to discuss on something which is as critical as innovation and digital and technology being at the heart of it. So as a moderator, when you have a diverse panel like this, it's always a tough challenge for me to be ensuring that we get the best out of every panel members. And second is also keeping a view that we are I would say, honest in terms of the topic that we are looking at. So just to tee it off, so we have been, since morning, we have been speaking about some of the things in terms of when we spoke about how the chamber has been working on digital, some of the things that they have been working throughout the years and have been at the forefront of some of the thought leadership around that. Now, one of the key things of why we look at technology or digital for that matter, because at the heart of it, and this is my personal belief, and I'm sure all of you would, or most of you would resonate, is that if we don't innovate, we don't progress. If we don't discover, if we don't shed our past, if we are enamored about what we did yesterday, we'll always be in a state of past, in a state which is not progressive. With that notion, I will just try to kickstart the discussions. And with I would say, I'm not introducing individually the panel members, sorry for that, but because we have the introduction, but I think I will let them maybe speak a bit when I introduce each of them. So starting off, I would say with Dr. Diwan out here, with the background that you have in, I would say, pharma, life sciences industry, and which is one of the key proponents of, which is driving the growth story for that matter in India, not only in India, maybe outside as well. So where do you think some of the digital enabled innovation is coming to the fore? Where do you think across, I would say, the value chain, where some of these most pertinent things are actually not only seeing the light of the day, but really making that impact? So if we can just start off with your perspective, that would really be helpful. Yeah. Thank you.
Thank you very much for the introduction and asking the question. See, as you said, that panel is diverse. I think the topic is also such a vast topic that we can keep on speaking on this for a very, very long time, but I'll try to get as much restricted on the topic as possible. Before I start, I would like to know from the audience, how many of you are from pharmaceutical industry? So 1, 2, okay, 3, right. So I think majority of you are from the healthcare or the allied services, probably in the medical colleges or as students. I must tell you that pharmaceutical industry is in and out, doing lot of clinical research, development of the molecules, but these are very, very difficult areas because the failure rate of these discoveries is very, very high. Majority of the things which we discover, we think that this molecule will be very appropriate for a particular disease. It turns out to be otherwise, and there are some side effects. There could be not as good the effect as it should have been. So the molecule goes into the drain and the whole money along with this is wasted. So if I try to show you as a pipeline, a big pipe is the inlet of money and a very, very small droplet is coming out as the ultimate drug. So this is normally what is happening in the pharmaceutical industry. So how we can reduce this waste? That whatever knowledge we obtain from the data which we are collecting over a period of time, if this big data could be collated by artificial intelligence, so the job of many minds put together, if one AI can help us and keeping that whole particular focus into place, we can save a huge amount of money. You see, as an estimate, we can save approximately worldwide $30 billion just by enabling AI in appropriate fashion. But this is a very, very beginning state of the affairs. And I would say that it is just like that when in early 80s, computers were introduced in India. People were scared, people were worried that computers are going to take the jobs of accountants, and that was a beginning. But AI is definitely going to help us just like computers did to everyday life in today's world. Now, I must say that the discovery, as I discussed, it goes through various phases. If we talk of the beginning, the targets are to be set as to which biological molecule you are going to target. Now, we have cardiologists in our panel, we have a lot of other people. You see, our body works on various enzymes and the molecules. So there are certain kinases. Say, for example, now what they are doing, they are transferring phosphate from higher to lower end, producing energy, driving the activity of the body, and all our secretions, all our contractions, other things, they are happening through those kind of enzymatic actions. And we know that all the inflammation, all the cytotoxicity, all the free radical generation, everything can be starting from that particular point. So now, understanding the basics, we can say that, okay, now what kind of molecule would be best to identify the cause of a particular disease. For example, there are Janus kinase, molecules. So from the hair fall to arthritis, there's a huge spectrum those kinases they cover. We call it as JAK1, JAK2, 3, 4, etc. But how do we know that this particular molecule is the culprit and my drug is going to be effective in this particular case? So what you need to do, you need to integrate all whatever has been discussed in the various papers, in the various small experiments into a big data. And if you are going to analyze that whole data, it is going to take huge lot of time. So what you need a helper, and that helper is in the form of AI. And it is the big thing which we are going to discuss now in further course of time. So because of the paucity of time, I'll keep on discussing point by point as it comes to that particular thing. Yeah.
And thanks, Dr. Devan, for basically articulating it in a very concise manner. And as I mentioned, we have a very varied panel, and I think what we will get from the panel is a diverse aspects as well. So I'll go to Ms. Kaushik out here. So with all the things that we are talking about now, how do we make, see, one is innovate, that when we innovate, how do we basically inculcate that spirit? Now from a education, from a training aspect, how and what do you think are some of those game-changing or some of the things which may not be nascent as well, which you think is being fueled, and what's been your experience around that? It would be very good to hear from you, ma'am. Thank you.
So when it comes to medical education, the first and foremost priority is that we ensure our students learn faster, they learn in the real situation, and also making zero errors, although which is not easy to say zero error, but at least we try to chase that zero error number. And this, keeping those 3 points in mind, the biggest innovation, or I would say post-COVID, the biggest innovation is we train our students on virtual reality and augmented reality, which helps the students to get those real life situations. They perform surgeries on that and they gain more confidence because it gives them the real life situation, it gives them that atmosphere. Secondly, what I have seen in last 2-3 years, that from a medical college standpoint, we have also incorporated our telemedicine, telehealth and medical education together. So when these students, through these integration of these 3 things, students also get the opportunity to understand how things work in a remote village, because that's where the masses are and that's where they get the variety of the cases. When I say variety of the cases, they get the exposure. They are not limited to only 1 or 2 or 3 medical condition from that area. When you go to remote areas, you also see the diverse kind of situations or patients coming from. So that's again some very this has helped and improved the performance of the students. And third, to be concise, is the integration of through the technology. We have been able to integrate the students from the other discipline as well. So think about medical students talking to an engineering student. That integration has helped to work on the innovation part. Innovation in offering the treatment, innovation in offering, in designing the implant. So that process is on, and I believe with the technology, this is going to help in the future.
I think that was useful. In fact, the way you articulated, because end of the day, technology, if you look at it, and what I'm saying is also to break some of these barriers about affordability, accessibility, making it something which is tenable, because as I keep on repeating, the Bharat is not the one that is here.
Yeah.
It's just much beyond as well. So I will now like to get Dr. Bose into the conversation. Now, with all the things that we spoke about specifically around the tools and technology, where do you think some of the current, which is the hospital systems that are there, the EMRs which are there, how and what is something evolving in that space? Is it something which we are seeing because they have been there? What, according to you, is maybe the innovation, if I were to keep that at the heart of it? What's that happening? And very importantly, how it's happening in today's world would be very good to hear from you perspective. Thank you.
Good afternoon. I am one of those few people in this discussion forum where I am at both ends, as an administrator and as a clinician also. So to understand and how to run a good hospital, you need to understand from 2 perspectives. One is the clinician's perspective and the actually who's treating the patient, and the other one is from the patient's perspective. So there are 2 perspectives which you need to take into consideration before designing any automation, anything that you want to talk about, any artificial or quaternary intelligence or any quantum intelligence that you want to talk about. So when I want to talk about any hospital information system that is prevalent in our country, when I have to choose, I have 2 options. When I choose, there are a spectrum of a hospital information system. They are known by various names, HIMS or HIMS as you said. So they are either bad or very bad. So you'll have to choose the bad one, and then they will tell you that you have to modify it according to your needs. Now that's a very difficult thing to do. Then you'll have to get your finance department, your billing department, your clinicians department, and operations and HR all customize. You have to customize according to your need. And that is going to take another year at least. And then after a period of time, they are going to tell you, okay, the time period has elapsed, now you have to, we'll take money for everything, every single change that you do. So we are at the mercy of these so supra-intelligent HIS developers. And they're actually very bad. Because hospital is a system which is very varied. It contains a part of the hospitality like any 5-star or general hotel industry. It is a combination of pharmaceutical industry, and it is also clinicians. Then you have the finance guys, you have the HR guys, and every clinical department has a separate need. To actually collate them into one single HIS is actually very difficult, if you agree with me or not. It is not developing a software for an aluminium factory or a dosa factory. So they have single line of these things. I also have an eye hospital in Durgapur, which is one of the best in India now. And we have developed a software for them. It's so simple. Patient coming in, ordering their queuing, going to this doctor, that doctor. Within half an hour, they take medications, buy a spectacle and go off. Because it's a laminar flow. So how many of you are actually working in a hospital? Please raise your hands. Quite a few of them. Now tell me, if you come to a hospital and see that it is a very crowded hospital. So one fine morning, my friend from Calcutta comes to my hospital in a small little village called Durgapur and sees that the hospital is very crowded. And he tells me, oh Shotajit, your hospital is doing so well, it is so crowded, that is not a place to put a foot on once you lift your leg. Then I realized that I'm not doing my job properly. That means the people are waiting for a long time, people are not getting to get their things done immediately. So then we developed systems where we lowered TATs, where we lowered a lot of things. And now, believe me, if you come to the hospital, the same guy would say, "Tera hospital chal nahi raha hai." But the throughput has reduced. That is thanks to a dedicated HIS that clocks every movement. And then you can further analyze and see how well you can reduce further. So that is very important, that to have a good HIS is like, you like having a Mercedes Benz in your garage, which is capable of doing 0 to 100 in 5 seconds, a big V6 engine. But you are using like a Maruti 800 going from point A to point B in half an hour from Salt Lake to Chingri Ghata. Or maybe Ruby Hospital, wherever. But if you are not able to use that Mercedes like a Mercedes, and if your guy is in the hospital is not capable of utilizing that Mercedes like a Mercedes, then there is nothing that innovation can do. You have to change the system, change the people who are using it. If they are permanent employees, you cannot get rid of them. So our job will be to train them to be able to use the software. And then, I'm just telling you the ground realities. Then, things like big data, edge computing, I'm also part of an engineering college, so where we teach AI and machine learning and deep neural learning and all of that. We are now going into quantum computing with quantum internet, which is a huge advancement. But to get into all this, our mind space have to change. And it is very nice that there are so many initiatives being taken from the government of India also to get into a digital space where all of us have a uniform health number, identification number, like our Aadhaar card. So if you just put in your number, you get everything around. When you had your last attack or something, everything will be there, so that you tell your number and you go anywhere, you get the care. But where is the uniform healthcare quality? That if I had a heart attack and I am in Baharampur of West Bengal and then I get another attack, will they be able to treat me? Or if they can't treat me, is that this rapid evacuation system where they will be able to take me to a place where I can be treated? No. So this is all these getting big data and analyzing them into prediction of healthcare, prediction of disease processes. So many things are there, but they are important. And to be telling you, we are running tertiary health centers. Somebody are doing quaternary quality of healthcare somewhere around the other. But you have to understand
that today we talked about Alzheimer's and all that. Tell me, in the city you get Alzheimer's patients. In the village, people don't reach the age to be getting an Alzheimer's disease because people are dying of communicable diseases like diarrhea, vomiting, dehydration, and fever and all of that. So our job is to get artificial intelligence, get innovative ideas, including the digital space, to get into that area where we can get proper sanitation, potable water, and ensure that, and find out what percentage of people are actually getting this to eradicate communicable diseases from the face of humanity in India, and then get into communicable and non-communicable diseases. But people have to live up to that age to get communicable diseases, and then to the stage where they get Alzheimer's disease. So my humble submission is that to Shantan, who's really an intelligent guy, I'm going to include him, take him to Durgapur to give lectures in our engineering college about digitization of healthcare and all of that. But we need to have a better understanding of the system, understanding of the end users. And this is what he's talking about, is that when we were young and we used to see Star Wars comics, some elder senior guy must have read it in our time, and then actually people are going to the stars and all that, and to the Mars and everything. And when we used to get stuck in the road trying to go to Howrah station, I used to wonder, can my car get a few wings so that we can jump into Howrah and get the train? But today there are flying cabs coming. So yes, it is good to dream, and our job as a collective will be to put such kinds of dream into reality. I am for such innovations, and thank you, and please take this into higher levels. I am with you and at every level to be with you. Thank you.
Thank you, Dr. Bose. In fact, just a small anecdote, in fact, about the HIS and EMA again, because I'm part of the fraternity, I always take it. So along with NABH, we are going to launch India's first standard to measure the maturity of all HIS, which is hospital system, and electronic medical records for India. It's in the works, where we are working along with NABH in the month of May and June. So this will be first standard that comes out to measure exactly like what Dr. Bose said, that do I know that how mature, how pertinent are they, and that will give them the confidence. We have already come out with the digital health standard as NABH. It got launched on 17 September. Some of you in this room might have already applied for it. So we have started taking those small baby steps, but a lot has to be done. So I'll, in that same, I would say, spirit, move to Dr. Lahiri. And I would like to get what we call as the physician side of it. Lahiri, that we have been talking about that this is innovation, this technology, but from a physician's point of view, what is the expectation? Where do you set I would say, the bar? And how do you think that we will go about it? It would be very interesting to hear from you. Thank you.
So yes, but taking cue from what Dr. Bose just enlightened us on, actually there is a quantum leap that we are looking at. Ground zero, where we are standing, it's appalling. It's absolutely an appalling state that we are standing now. And what we're visualizing and what the panel is all about today, AI and the physician's interface and the different specialities, well, that's a huge quantum leap, and really, all of us out here would love to be a part of when it actually happens, right? But just to give you a snapshot of what it is and why we are discussing that here, I'll take you through the different specialities where AI is doing, and there's quite many discussion points around the radiology, the pathology, the cardiology, and also the dermatopathology aspects of AI and the physicians, how it is going to aid it. Basically, well, yes, I am a bit of a positive thinker, and I do not think that AI is going to be a job killer. It is not. It is actually going to collaborate. It is actually going to support the physicians, the clinicians in a big way. And just to give you a snapshot, say, when we talk of radiology, we have all heard about CT and MR getting done, right? CT scans and MRIs. Now, small data points, like, in USA, whatever is per 1,000, around 250, 258 numbers of CT scans and MRIs, it is, in Indian scenario, it is only about around 38 per 1,000. Now, if you ask me why, the main difficulty is in India, the whole diagnostics is urbanized. Now that is very difficult because most of the specialists are actually focused, with due apology to Dr. Bose, definitely he's doing a huge, immense work there. But most of the specialists are having a big, the focus is on the cities, in the metro cities. Now, AI is going to immensely help help the general people and also the physicians. How? Because, a very simple thing that we all know, this turnaround time. The general mass, they want a quick fix for everything. So if I'm having a headache, I would need to get a scan done. That needs to be done in a moment, and the report should be in my hand in a moment, right? Now, how AI would help in it is, like we discussed about databases. Unfortunately, I'm not very sure where we are right now in the nation. But AI in the long run is going to help us in precisely analyzing that, somebody, a lady with my height and my weight and my Asian background with headache, what are the propensities of having what kind of disease? And that will be interfaced with the radiological findings. And that actually is going to help the physician looking at the report. He would be having a very, very focused kind of provisional diagnosis point to be made, and maybe, yes, going ahead, we'll be having more better clinical care. Again, if you look at pathology, now it's gross, but yes, it has been observed that around, say, there's a dip of about 18% when we talk of pathologists. So we are having lesser number of specialists, and this is in USA. So what is, on the contrary, what is happening is, if you look at the number of cancer patients which are increasing, so 2020 says around about, say, 19 million patients had cancer. Now, our predictive value in 2040, so around a gap of 20 years, there is expected to be a hike of 48%. Now, isn't that immense? So with that huge amount of cancer load, what we are talking of is the immense, just imagine the number of slides a pathologist used to see personally earlier, and our professors, and how many they are going to screen now with days going on, right? And more you see, our doctors would get fatigued. Our doctors would definitely head on to have a burnout. That is but natural. So how AI is going to help it is, there are, newer modalities where the glass slides are, scanned and made available, and, even the cells are getting observed by the computer, and more informations like, the morphologics are compared, so that the pathologist sitting there before reporting, he is very sure of what he is doing, and there is even a chance where the AI would question the manual reporting of the pathologist, and errors would be less in that way. So I guess going ahead, if actually these things sees the light of the day, our clinicians would be very, very well armed with precision in their technical areas. Same for cardiology, like AFib. I really don't think that we are much doing on detecting atrial fibrillation much, but that is one aspect, one disease which is curable, provided we have picked it up. Now all of us are wearing wearable gadgets, many of us in this room are. So the wearable gadgets actually pull on the data to the live system, and there's an immense amount of data out there, which when analyzed will actually help the cardiologist in detecting those. So it goes on like this, and actually I just heard recently that PGI Chandigarh, the pathologists, especially sitting out there, they're getting slides from remote areas, and so the clinicians sitting in remote path labs, they're sending the slides up there to the PGI Chandigarh specialists, and in no time they're getting the reports, so that actually helps, in the clinician's decision making. I think this is what.
No, I think that was very valid. In fact, see, there's a power of intellect which is sometimes concentrated focus, as you mentioned about from an urban Now, how do you break these barriers? Because with the geography that we have, the diversity that we have, you have majority of the masses, at least 80% of it outside the urban. But our health facilities, assets, all the things that we are talking about, they are still very urban concentrated. So one is using tech to be that leveler, that enabler, that reach, and obviously to break that barrier in terms of affordability also. So there is a thing. But at the heart of it, what we should also, and this is something I thought as a, like we should also keep that the quality aspect for it, because whatever we are talking about from a healthcare point of view, when we make it affordable, accessible, it's quality which has to be at the, really at the core of it, because we are dealing with lives, we are talking about, I would say, care being given. So there is nothing as a subscale quality. With that, I would say, I'd like to get Dr. Bhaumik in the discussion. Now, all the things that we are talking about, I would say the upscale insights. So where do you think, and this is the TO thing, that where are some of the things that some of the challenges, some of the things that we need to be very careful about? I'm using the word careful, which is not sounding negative, but being cautious about it. And where do you think that we need to be focusing, and what's your perspective? Thank you on that.
So good afternoon, everyone. And at the outset, let me thank the organizers for inviting me here. So it's a privilege to be a part of this panel. I think we will have to first look at statistics on why we are going to go digital. I think COVID-19 taught us that the world can function even if people don't meet, you know. So that has been the greatest catalyst. Even the hospitals, Dr. Bose was mentioning, I'm sure it was not that crowded during COVID-19 except for COVID patients being wheeled in. So every hospital, in my hospital in PLS, we had only COVID-19 patients wheeled in, but didn't we care for other patients? We did. Why? Because India was one of the first countries which devised the telemedicine guidelines. So not many people are aware of it, that telemedicine guidelines gave the birth to this particular movement which India was actually sitting on. But this has been a catalyst that telemedicine could be practiced, but what people don't know is that it can be practiced only in the country. So people have been doing this for Bangladeshi patients, for patients in Bhutan, for patients in Sri Lanka. Question is, are we implementing the law? That's one big thing. What are we consulting? The guidelines really clearly say that you can only consult chronic diseases. But if somebody is having suicidal ideas, you know, people would like to go up on that. There are companies, and excuse me for saying this, there are companies who are making out money on everything possible. So, you know, come digital and, just go to the market and sell everything. And people are now saying that, psychiatrists come online and, you can actually practice psychiatry online. Does the government allow it? I think that is what we need to actually understand. What is a regulatory framework? We are very proactive in approaching and adopting new technologies, but when we look at regulatory framework, we kind of neglect it a bit. That's one of my biggest concern, because antibiotics, believe it or not, cannot be prescribed online. But people are doing it. I mean, how many of you must have taken antibiotics prescribed online? You just can take chronic diseases. So I don't understand that whether antibiotics can be chronic or not, except for few conditions, which is like anti-tubercular drugs. The other thing is, I'm going to look at the ecosystem in terms of how India is placed in terms of managing digital data. You know, we are collecting n number of apps. You know, you have an app for everything. If you're happy, you have an app. If you're obese, you have an app. If you're thin, if you're you have an app. If you're single, you have an app. So you just go into the app and put in whatever data possible. But what is happening to that data? Who's analyzing the data? Who's accessing? So glad that the Indian government in August 2023 passed the DPDP Act, which I would say is one of the first in the developing world, which says that not only the Indians but non-resident Indian data has to be captured and kept properly. This is extremely important for companies who are dealing with the human data on a day-to-day basis. Dr. Lyrie was mentioning about the heart rates. I mean, we can look at heart rates, and then we can also predict this person can have a heart attack, and that report can go to the HR. and that HR can terminate that person. I mean, look at those kind of aspects that whether the HR will be ready to pay for that extra cost. So this is a double-edged sword. We need to be very careful about how the data is being accessed. And let me tell you, being the head of research at my hospital, there are multiple countries in the world which is now looking at Indian data. Everybody wants Indian data because in America, every fourth patient is an Indian. In Australia, every sixth patient is an Indian. In England, every second patient is an Indian. So they want to come to India because they cannot go to those countries and figure out what their genetic analysis is, how they look like, what will be their outcome if they are on anti-obesity drug over a period of time. They are all doing their data dredging. I know Dr. Diwan is here, so I'm not going to ambush the pharma industry, but India is a long-hanging fruit for them. So we need to be very careful when we are handling these data, because many a times we have a very good organization, ICMR, Indian Council of Medical Research, which is categorically saying that if you are taking away Indian patient data to any of these servers outside the country, you need to have what is known as an HMSC clearance. I mean, how many of us in our hospitals actually do it? We know it. So there's a lot of capacity building which is required, not only in terms of handling the data, but I would say also these platforms need to be utilized for training the administrators, if I could say. Many of the administrators who are both from the government as well as from the private, they are not aware that what data could be handled and what data could be handed over just because some money is being offered. So we need to be careful on that. And lastly, I think the very, very important thing is that what kind of information is being fed into and what is being derived. So last week we had a company come to us who said that they are looking at a database of the routine test which people do as a part of their the well-being test. And we were very curious to know, why would you like to have this entire database? They said, we'll pay you XYZ money, but what they are trying to do is they are trying to predict what kind of diseases are going to come in the country so that the appropriate drugs could be developed over a period of time. I am a person from research and I strongly support it, but if this is only looking at one particular gene and trying to prove that a particular section will not do good over a period of time, we need to be very, very careful. Because we are 30 countries together, I put it. People in Chennai are different from people in Jammu and Kashmir, and people in Gujarat are different from people in Bengal, and we are not even looking at Northeast. So European Union, you will have a hard time because I work there, so you will have a very hard time getting out data from those countries. Let us make it more reasonable for the data to be accessed. And I'm a strong believer that data utilized in the proper ethical way. We have done it in diabetes. I can give you an example. We ourselves with Southern Indian Institute have developed an app where simple things like what food you eat, what is your HbA1c, what is your blood sugar level, what is your BMI, you can put it through and it will predict over a period of time your insulin resistance, which my colleagues from medicine will know is a first marker to go bad if you have diabetes. So if you utilize it in the proper framework, this can give you, wonders. But we need to be very, very careful. Again, I would say, highlight that Indian government has a regulatory framework. We need to be very careful about the regulatory framework as well.
Right. No, I think you harped on the part that in the garb of, I would say, innovation, we cannot not be responsible. We cannot not neglect, because end of the day it's patients' data that we are talking about, which is the same classification as a sensitive private information. And thanks to DPDP, I think we have that on ground. So if I were to just we have as a next round, just what would be the expectation? And I think we'll just do a quick round robin across the panel. That what do you think is the expectation from, I would say, the Indian fraternity, whether it's a government regulatory body, that you think will basically give fuel to this innovation streak, which is, and if I can tag it as a responsible innovation, if I were as a panel, if we were to think about it, we are talking about innovation which is tech enabled, but that's responsible. So Dr. Devan, a quick response from you that as we go, what is that fuel that we would need?
See, from the government point, what we need is a network which is enabled by the government, and in a way that there is a data privacy which is kept on the utmost, and then the science should also get benefit out of it. I can give you some examples for this. For example, in IIT Powai in Mumbai, there are metabolomics, genomics, neutrobiomics, kind of things which are being worked upon. The data is being collected from various hospitals. Those are being integrated, and they can tell you what kind of food is good for you so that you don't have the diseases in future. You see, if we go into the, say 30, 40 years back, a Bengali would eat Bengali food, North Indian like Punjabi would eat Punjabi food, South Indian like, in Chennai, they will eat their own kind of local food. There was very less mixing up of the things. But now the mixing is so much. Over here, the Punjabi food will be more prevalent. In some other area, the Mach Bhat will be more prevalent, which was not earlier, So are our bodies meant to adopt those kind of situations? That is being studied on a very regular basis, but if the data is not kept properly, it can be a very, very difficult situation for future generations to come. So we have to request governments to have centralized data networking, which could integrate, the big data and kept it private too.
In fact, the UHI that I think we are talking about is exactly on that. So I'll go to Ms. Kaushik. So what would be your quick one ask? And I'm just trying to get the panel as a common platform. Maybe we can articulate this as something that we were able to work together as a panel, as a representation. Representation might be a strong word to use. So quick thought from your side, ma'am.
So on this panel, I'm the, I guess, non-medical person, not a doctor.
Even I am not.
So, yeah. So my take on the technology part or any innovation is, first of all, when it comes to healthcare, healthcare is not metro cities. So whenever we design something, we should think of the population which is outside the urban area, who doesn't have access. As Dr. Satyajit said, that Parkinson cases are very rare in the metro cities, tier 2 cities, because they don't reach to that level. So currently what I feel that technology should be designed keeping those people in mind. Because the first and basic foremost thing for healthcare technology is to reach out to those people. Now the challenge when it comes to the real Bharat is that whatever we design as should be affordable, accessible, and it should have a cultural relevance, because then only people are going to use that technology. Technology which I use, or an Apple Watch which can tell me about my health vital, will not work for a guy who is in a village, in a remote village, which is expensive, may not be able to buy an Apple Watch. Am I offering him a solution through which he can at least understand those vital status? Here the challenge is he should also know that I have to monitor these things. These are important for my health. So awareness, and also ensuring that that they are able to afford it. That affordability piece and cultural relevance is very, very important when it comes to innovation. So my take as of now would be at least design something which reaches out to the real Bharat, which reaches out to the real, I would say, audience who can use it and make their life better through these innovations. So any innovation, if that keep the end user in mind, will always work. So for this platform, I was looking at some examples which I can give when it comes to healthcare. Unfortunately, I don't have any example which I can quote here where technology has helped the real masses. But To understand the concept, think of the Paytm voice box. A cobbler in a village can also understand that. So we have to make the technology so simple and so relevant that anyone and everyone in the country can use it. Thank you so much.
Thanks. Dr. Bose, quick round from yourself about this as a representation.
Yeah, I can give you a small example. In 2000, what she said was, accessibility. It's very important in healthcare. So, G is not paying any money for me to talk on their behalf. So I'll just say we bought some ECG machines which are priced at 30,000 or 40. I don't know whether they're still around or not. 30,000 rupees, which is Wi-Fi enabled. So we bought 10 of them, and we had 10 of these technicians going around. So we call it a program called, we gave it a name, and we send it to all the villages. And so whatever ECG they were doing, the ECG would automatically get mailed to our cardiologist. And we would be able to then identify, as she said, patients with atrial fibrillation, or maybe patient with a complete heart block who was having repeated blackouts, and would then come to us, and we would then treat based out of various schemes which are fed by the government and things like that. So that is just a small thing. But now it has gone to a certain level in which there are companies that has come up. In a mobile phone, you have got an app, and they give you a small little transducer, which can be used as any kind for the heart or for the ultrasound, and you can actually put it in front of your heart, and it will be able to give you images which can be interpreted by a cardiologist sitting somewhere else. So these are various innovations that are coming out where accessibility is important. Even in the West, you don't have doctors in every village. We've been there and we've seen all of that. So you have nurse practitioners and all kinds of people, technicians who are doing all that. Even operation theaters in the US don't have a doctor who's assisting a cardiac surgeon. You have physician assistants. So when there is a lack of manpower, you have to involve people, you have to upgrade their skills and use technology like this so that you can make healthcare accessible. I'm just giving you two such examples. And I'm sure there are many things that you can do. You can pick up with the help of that small little mobile app. You can pick up, there are so many health tech companies moving around. They can actually evolve, get into this kind of space and create an accessibility situation where healthcare actually you can be identify diseases which are just formed rather than come into a phase where they lose their lives or of a complete heart block or advanced cancer and all of that. Thank you.
Thanks, Dr. Bose. So, Dr. Lyrie, as a representation point, if you have to try to collate that, what would that be which you think is the fuel needed?
So what I was just wondering, listening to all of our panelists, see, it's beautiful to dream. It's wonderful to feel positive and think of a future which is all lazy and flowery. But at the same time, let us keep our feet grounded and remember the risks associated. So Dr. Subhrajyoti has mentioned about the data leaks, about the the way, the information gets leaked from here and there. And so what I was just wondering, nothing surpasses human intelligence. All of us, we must remember that for life. So first there is human intelligence, then yes, there's artificial intelligence. But all of us, we are very wary about something called Jamtara intelligence, isn't it? So, that is very scary. So with all the data points coming into different places and impatient, everybody, all of us, we are so impatient, we want everything at the snap of our fingers. So yes, an app for obesity, an app for this, an app for that, an app for snoring. Yes, how many times I snored at night, right? So, but what happens to my data? So, yes, there should be regulatory boards. I'm sure the government is looking into it very stringently. We wish to grow, but we wish to grow in a safe way. That is one point that I was wondering on. And then again, yes, some point, I guess it was Dr. Bose who mentioned, it is very important to study the mass before taking a quantum leap. So, before even we think of detecting AFib or detecting whatever, but we should understand who is our target audience, what is their skill set, what is their intelligence, right? Before actually, because everything boils down to cost. So I might want the moon, but do I have enough mullahs in my pocket to afford the moon, right? And even if, whether actually I do need the moon at my hand, that is very important. So it's very important before we jump and into the bandwagon and have an AI-driven pathology, an AI-driven radiology, an AI-driven everything on earth, to understand, how much do we actually need it? Yes, we need it. We are not negative about it. We need a portion of it maybe, but let us understand the exact portion that we need it, so that we don't waste huge amount of resource, whoever is paying for it, whoever is it. So let us value money that is there. So that is what I was wondering. But at the end of the day, isn't there a little bit of a doubt that are we going to, what happens to the technical efficiencies of the pathologists and radiologists? Say down the line about 10 to 15 years, are we trying to, mutate them and cut them short of their intelligence a little bit maybe, and they will become a bit more lazier? Am I sounding negative? But no, that's it from my end.
Thank you. Thanks, Dr. Larry, for articulating that. Dr. Bhomik, I think rounding off the word of cautious plus optimism and representation.
Absolutely. I shouldn't come out as a person who's very negative. I am to reply to Madam Kaushik's thing that what is the example in healthcare? It's Shankar Netralaya. If you look at Shankar Netralaya, they used to take this big van, and now the van size has decreased. I'm talking about 15 years back, when the cataract surgeries were being performed by one very less trained MBBS doctor who was trained in Shankar Netralaya, and they used to go miles and miles away from Chennai. And there was this huge, they used to project their huge antenna out of that van. So millions and millions of patients in India have actually got this AI thing, or it was accessible the moment. Because I went to Shankar Netralaya and people were saying that the person who was leading it said that moment they saw the van, they used to all stand by because that was quality, credibility. If you look at ECG markings, ladies and gentlemen, AI is there for last 35 years. It already gives you normal ECG, abnormal ECG, RBB, LBB. So AI is already there, it's existing. It's just that whether we accept it or we don't accept it. Why don't we accept it? Because we go to the specialist. So what we need to do is to bridge the gap. We need the MBBS curriculum to have a course in technology. Unfortunately, NMC does not still believe that. And we need to also need the engineers and the managers to believe there's something known as empathy, which the technology will never be able to provide. When you hold the hand of a doctor, when you're having a heart attack, I'm sure Dr. Bose has done this millions of times, and that person has felt immediately, felt 1,000 times better, even if he had the worst heart attack. That technology will never be able to bridge. The other thing which I want from the government is no voluntary registration. Nothing happens, either voluntary, kuch nahi chalega. Voluntary Aadhaar registration, nobody will register. If you say voluntary, do your pollution control of your car, anybody will do, I will not do. We will be the most polluted city, already we are, we will go 20 times ahead. So you have to mandate registration. Registrations have to be made mandatory, just like Aadhaar, so that our health data is getting into the system, so that we have our own data. We don't look west. Because one size will not fit all. In healthcare, the West data cannot be extrapolated. Our genes are different. We eat differently. It's a different thing that on weekends we order more pizzas now than we order anything else. So we are looking at that. And lastly, I would say that very, very important is we need to think globally but act locally, which all our people are saying. You know, we will have to take our own solutions where ophthalmology, radiology, as Dr. Lyri was mentioning, we have very less radiologists in our country. So will these patients, if you have a normal chest x-ray and if you're having cough and you're waiting that maybe the next 7 days I will go to a district hospital only to show a normal chest x-ray, the district hospitals have to implement this technology to tell the person, hey, you know what, you have a normal chest x-ray, you are probably a patient of reflux disorder. You need a reflux disorder therapy. So that's what is going to make it very, very important. And again, I would say that India has huge potential. If we do within the regulatory framework, India can actually showcase how we can predict diseases, because again, we are so genomically different. We are genetically so different. We have mixture of all kinds of people here. We also have a lot of foreigners who come and stay with us. Our database can be actually, if I could use the word, I don't know if that will be liked by all, sold at premium rates to countries like United States and UK, and we can make millions of dollars out of it. So having said that, let us be positive, but let us be realistic as well, that, you know, we don't go overboard to sell everything.
Absolutely, I think said it very right. See, at the end of the day, healthcare is still provided by physicians. It's enabled by technology, aided by technology. It's still that, if I can use that, I'm sorry, and I'm actually guided by your thoughts. It's still guided by, as Munna Bhai said, that jadoo ki jhapki. I'm not saying, I'm not a physician to say that's what heals, but that's what helps to heal. And a technology is an enabler. Dr. Bose wanted to make a last comment, Mark. I will leave it to him to really draw it to the conclusion. Thank you.
So yeah, we had a very fruitful discussion today. Digitalization of healthcare, we have made a lot of inroads into it. And we will, as he said, enable and assist us to take decisions, but they will not replace doctors. That's the point. But here, there is a new tsunami that has hit our healthcare ecospace. It has already been hit by two things. One is the one from center, namta budo hoye gechi to. Na bol na oy je Ayushman Bharat. We are asked to do cases, I mean not in West Bengal, asked to do cases which are, do bypass surgeries at 1,50,000 and all that. And then we have a similar one in our state also. Yes. And new thing is coming up. There is a Supreme Court directive yesterday. If the government cannot give certain details to the Supreme Court by the end of this week, all private hospitals have to treat the patients as CGHS rates, which is very good. We want to do good to people, but what will happen to the hospitals, private hospitals, so to speak? Because the cost of treatment in a government hospital is very high. If you were to, calculate at every point how much is the expenditure, because it is taxpayers' money, nobody knows, and it's free to the end user. But in a private hospital, where all of us are belonging to private hospitals, so the cost, the EBITDAs and the PATs are coming down day by day, except for a few big houses. And there is another change that is taking place. All the private hospitals that are in different parts of the country are being purchased by private equity players. So that is another change that is happening in healthcare space. So if you want to round it up now.
Thank you. Thanks, everyone. I think thanks to all the panelists. Hopefully, we did not satiate your hunger too much. I think the lunch is around the corner. But thanks for being a lovely audience. We're not taking questions here, but we are right outside of the lunch place. So we'll be happy to have any questions that you have over lunch. Thank you. Thanks for all the panelists. Thank you.
Thank you, Shayantan and the panelists for this interactive session. So we have now a pleasant task to perform. I request Dr. Satyajit Bose to please present mementos to Mr. Shayantan Chatterjee, Executive Director from PwC. to Ms. Sandhya Kaushik from Jagannath Gupta Institute of Medical Sciences. Dr. Bhupesh Diwan from Zuventus Healthcare Limited. Dr. Shubhrajyoti Bhaumik from PLS Hospital. Dr. Sudeshna Lahiri from Ruby General Hospital. I now request Ms. Angana Guharai Chaudhary, Assistant Director General from Bengal Chamber, to please present a token of appreciation to Dr. Satyajit Bose. I request all the panelists and the moderator to please be on the dais for a photo session. Thank you all. Now we will have a lunch break. We will start the session after lunch from 3 o'clock onwards. I request all the delegates to please take their bags and belongings, because we will be doing a change in the setup. We will be doing some change in the setup in the room, so please carry your bags and belongings. We are proceeding with our next session, Generation AI Research to Wellness. I request the moderator of the session, Mr. Rajiv Sabarwal, partner PwC, to please be on the dais. I also request other panelists to join us. Dr. Shanta Datta, Director and Scientist G, ICMR, National Institute of Cholera and Enteric Diseases. Mr. Debashish Mojumdar, Country Head, Fujisoft India. Ms. Suparna Sengupta, CEO, IQCT Medical College and Hospital. I request Mr. Sabarwal to please take the session forward. Mike.
Thank you, Sarvani, and thank you for everybody who's attending after lunch. I'm sure you guys are half asleep, but hopefully this conversation will be good enough for you guys to wake up a little bit. So we're going to be talking to this August company about what is the impact of AI, Gen AI in healthcare research, and how it is changing lives of people, or how it has the potential of changing lives. So before we start, okay, I just wanted to talk a little bit about from the Western perspective. I spent some time in US, okay, and actually I live there. I'm here on a network role. So I've been working in the healthcare industry out there, and AI and Gen AI is kind of taking root exactly the same way it is doing in India, okay? Very important, everybody talks about it. Whether they understand it completely or not, that's a different issue, but everybody talks about it, and it is playing a significant part in the research and development aspect of it. For example, the life sciences companies who used to take almost 3 years to identify a molecule, okay, for a drug, okay, are taking less than 3 months in some cases. There are various registries of different molecules that are available, okay, which are ready for solving some of the disease conditions that have not been yet solved, okay, or have not been effective, the therapeutics have not been effective. Also in the healthcare side, a lot of work is being done on the digital twin or patient identification, patient progression of disease, etc., leveraging AI, how to figure out what the patient's health condition is going to be 5 years down the road, depending upon their current health condition or socioeconomic condition, etc. So AI and Gen AI are here to stay. And we are talking not only about defense industry or other industries where there are direct use cases for AI and Gen AI, but even in healthcare where people are still trying to find out some of the use cases. So it's a good topic to talk about. And this company that I have out here, they are the expert in their respective areas, all right? So we'll talk about that. Dr. Datta out here, as Sharbani said, is the director of ICMR, okay, and senior scientist out there, has spent a considerable part of her life on figuring out infectious diseases like cholera, etc. And Debashish out here is the country head for Fujisoft, who are doing some very innovative, very state-of-the-art technology tools, okay, to support use cases for healthcare leveraging AI and Gen AI. And Suparna out here runs one of the very unique setup in this country where we call as AMCs in US, academic medical colleges, all right, where it's a cusp of it's an integration of academia as well as actually practicing outcome-based patient support. So without any further ado, I'll just introduce these guys, and if you guys want to talk a little bit more about yourself.
I'm Dr. Shanta Datta. As I have been already introduced, I am holding the position of director of one of the ICMR institutes located in Kolkata, ICMR, National Institute of Cholera and Enteric Diseases. I think most of you might have heard about this institute because we had a very big role or important role during COVID pandemic. We were the institute where actually first the COVID from positive patient was identified from this eastern region of India, and then this is actually under the umbrella of ICMR. All the 27 institutes were operational during that time, and we have served West Bengal and other eastern regions. And actually now there are many. We have a virus research diagnostic lab, so which was open during COVID time 24/7 hours, and we were there are many viral diagnostic lab now in West Bengal and other eastern states, but all the faculties, whether government or non-government, they have been trained by NICED, and now also quality check. We are the authorized institute for quality check of the testing, and we do go for quality assurance and quality checking control of those. Many of those are also already attending this health tech. So we are doing that, and as per our recommendation only, the ICMR has given the approval for the independent testing of the labs who are independently testing for samples for COVID. And on my personal front, I'm an out and out researcher. My passion is science, and although I'm a physician by academically, but after I possessed my post-graduation, I entered into this institute. I have spent 30 years in this institute, And in between, in service, I have done PhD also from Kyushu University, Japan. And you can say research is my passion. I want to do more and more collaboration, more and more research. And for the benefit should percolate to the common people and also the downtrodden people, because although we sit in this like in this kind of health tech or seminar or a meeting, whatever you can say, in a 5-star or 4-star hotel, but whatever we will do, that we do for our common people. If the common people are not benefited by the research, then I don't think there is no, specifically country like us, where 80% of the population, they live, either they're mediocre or come from low socioeconomic status. So the research, the outcome of the research should go to those people. They should be trained, they should be made educated so that they can understand little bit of the research and they can have the benefit of the research. Thank you.
Thank you, ma'am. Good afternoon, everyone, and thank you so much, Mr. Sabharwal, for introducing us. My name is Debashish Mazumdar. I represent Fujisoft Incorporated in India. We are a 54-year-old technology company, mainly into the areas of embedded systems and core technologies. We develop solutions for the Fortune 500 electronic companies across the world. And one of the areas that we are working are obviously the medical electronics companies, wherein we create the solutions, we create the software behind it for these various, whether it is an MRI machine or a CT scan or let's say an endoscopy device as well. So in today's discussion, I will touch upon the various points of how the technology progress is happening using the various AI MLDL tools, and what is the outcome in terms of how they have been used in various cases and what is the positive outcome of it. Without further ado, I'll give the mic to my other panelist over here who will introduce herself. Thank you, ma'am.
Thank you, Debashish. This is Shuparna Sengupta. I'm working in IQ City Medical College Hospital. It's in Durgapur, a tier 2 city of Calcutta. Most people here know. And being in the tier 2 helps me understand, because I have been working like around 27 years in the hospital industry. So now first time I have started working in tier 2. And I can't tell you what experience it is actually. I mean, we have been only talking about, some finer things of life. But I think when we reach up to there, the other panelist in the last session was mentioning, the largest population is actually there. And we have hardly done anything. We have not even reached where we should be. I think everybody here, we should have that endeavor. I think this session would give me that privilege to learn from all of you, like how best I can do. The hospital is 1,200 beds. I can tell you almost 50% of the patients are treated free there. Now people will say that you're a private medical college, you are supposed to treat free patients. Not like that. There also people are so skeptical. Even if you tell them कि आप आओ, आपको हम देखेंगे, please come for free. People are thinking, नहीं आप तो कहीं से पैसा लो ही लोगे. So, so people have that kind of feeling that there always been, money. It comes first and not their, health. So I think our owner, he's hell-bent. He keeps on telling us that it should be a no-refusal hospital. Not a single person should go home without any kind of treatment. So the thing is, maybe the future, I do not know where it is. But with this Gen AI coming in, I think people around the world would be benefited, but I think the most benefit should pass on, as Dr. Datta was mentioning, to the people who have not even had that, the first come benefit of a right to health, which is our fundamental right. I think we have not even given that to them. So let's see how it goes.
Thank you, Suparna. Thank you, Debashish, and thank you, Dr. Datta. That was pretty nice, okay, very enlightening. So Dr. Datta, I'll start with you. You talked about extending the care to the rural masses, extending the care to the people who actually need it, okay, throughout this vast landscape of India, right? So I wanted to understand from you, what do you think, how Gen AI or AI-based solutions can actually help you extend that care that is usually available in tier 1 cities to the rural masses? How do you think it is gonna do?
Thank you for this very important question, and it is close to my heart also, you can say. So it is not very easy task. First of all, I must say that health means it is well-being, it is physical, mental, and psychological well-being, free from all disease, and also well-being of the person, so that he can live his life. So for that, the most important thing that if he suffers from any illness, that should be diagnosed early, that should be treated early, and if there is any provision of prevention of the disease, that also should go or should reach to him. So first thing is that I was discussing with Dr. Sabarwal regarding like how we can do this, like outreach. They don't know what is AI. AI, this is a very common term which is being used within the health setup very recently, and the technology people, they have been doing as per the need of the healthcare healthcare experts, but the common people, they don't have idea what is AI and how they can utilize AI for the benefit of their health as well as psychological and mental well-being. So for that, outreach program is very important, and education of the common mass, like what is AI, how it can like solve the problem, as well as it will ease their life. Like I can give you one example. 20 years earlier, 2001, we did not have any mobile use. We were like, first, I think 2001 only it came to India. One very handful of people were using the mobile, and most of the people, they didn't know anything about it. But what has happened after 20 years, now you can see mobile is being used by anyone, everyone. Even any shopkeeper, anyone can use mobile. So how it is a revolution. It will not come in a day. So, but all of us, we have to be careful, and we should take the responsibility of percolating the benefit of the advanced technology like AI and machine learning to the people who actually they need the most, and they don't have any exposure of this kind of technology, they don't have any knowledge of this kind of technology. The first thing we have to look at, what is the need? What is our need? So you have to, this is a brainstorming session should have been there, so that the technology-based needs should be identified. It is not a part of, it is a part of the hired expert group. They should first discuss what are the needs in the health sector, where these AI as well as machine learning can be applied to make it easier and to make it reachable to anyone. Like it should go further down the lane. Now, when it has been identified, then we have to think, actually there are these, again, these are the 5 steps of technology need assessment. Like how we will say that this is the technology, if it can be used for this purpose, this becomes much more easier. So for that, again, if you find out the need, and then what are the technology can be used, whether it can be used in-house technology or we have to borrow it from Western countries. So even if we borrow it from Western countries, there should be technology transfer, and that technology should be adopted in our country, so that anything which is related to this technology base, that will be very cheaper. If it is a product of India, obviously it will be cheaper, and then it can go to any person, even to the poorest of the poor, they can avail the facility. Now, for this purpose, the AI has now, it is being used in health sector in many steps. Like I can give you a list where AI can be used for the ease of the treatment, for ease of the diagnosis, for ease of the, so these are issues which we have to find out, point out, and then AI can be used for addressing these issues, and then technology can be developed, and that technology should be made user friendly, and then it should go, they should be educated, the common people, or the outreach program we have to make, then it should reach to them with very little cost. If it is too expensive, then they cannot afford to have that. So these are the basic things or the points we have to think about.
So that was very enlightening. So if I have to summarize, you're talking about first identify the need for the technology, just don't use the technology for the sake of it. Second, kind of identify what kind of technology, do you import it or do you have it indigenous, so that you can figure out what is the best suitable operation for it, all right? Then third stage is make it very cost effective, because India is not a very rich country per capita. And fourth thing is how to educate people around that technology. So that's a very good list of steps, all right? So Suparna, I will go next step to you, because there is a corollary out here. You lead an institute also. The doctors who are gonna go into the market and who are gonna actually help people take care of their health, those are the first line of defense, so to say, all right, in order to educate them. So how are you leveraging AI technologies, or how are you making your future doctors aware of the AI technologies and the benefit of it, so that they can implement it in their operations as well as educate the masses that they come in touch with?
See, though I look after the hospital, I'm in charge. I'm not a doctor also. But see, what happens is the education, I mean, the fundamental thing which we are doing is training medical graduates. So I think it is going to play a very large role in the future, because I could see that now with the new curriculum coming in and the new structure of, like NEET structure, the gateway to medical students, has taken radical changes. Now everybody is supposed to get through medical, if they sit for it. So there are a lot of, gray area which I don't want to talk. Now what happens is, previously we were like, there are 5 colleges and you have to be a JIPMA, you have to be a AIMS, you have to be a CMC, or you have to be a PGI Chandigarh or Calcutta Medical College, then you are a doctor. Okay. Now there are like thousands of medical colleges have come in. Now what is happening, there is a, learning curve, what you say, is not actually what we thought it was some 10 years back. Now students are coming from different places and with a different educational background. Their knowledge and skill cannot be measured. They are not having the same kind of, like anybody who is passing a NEET, anyone, you can't compare actually. See, there are definitely, gradation is there, the score, who scores high or scores low is separate. But when they come into the medical field, there's a mixture of students. Now, I would think that with the coming of AI, the number one thing which will help them is learning their own knowledge gaps. Is very, very important. So the learning solutions can be moderated such a way that they know at what pace I can learn. Because coming from just school straight to medical education itself is a huge leap. And it's a complexity of the cases and all this. So this learning algorithms, which I could say, would help them monitor that where is my knowledge gap. So that would help them to do self-study. So people are like now understanding that, yes, I have to concentrate here, or this is my weakness. That will help them. Because now it is a world different, professional world. a dog bites a dog kind of attitude. So you can see so many people are committing suicides in medical schools. Why? Why it is so high? Because people think, see, it's a huge leap from the school to the college. So I think this kind of things will definitely help. Secondly is simulation labs. We have already started into that. So simulation labs would definitely help. Now, some few years back, we were bringing the cadaveric cases where, like suppose a particular workshop was done where, people were performing on cadavers, where particular surgeries like joint replacements or arthroscopies, complex shoulder surgeries were taken, workshops were done. And now with this help of the simulation labs, it's becoming so easy. It's a very, very easy transition, and they can do number of mistakes, but they don't have to do it on a real body, human body. Yeah. They can always get through this, and then, I think the precision, we can say, it will help in precision. So these are the things actually I was looking forward.
So that's very interesting. In fact, I was very impressed with the first point where you talked about how the education system can also be kind of adjusted or tweaked, so to say, so that you're actually identifying your knowledge gaps rather than having to go through everything which is going to be useless in your career downstream or which you already might know about, right? So that's a very, very interesting point. Okay, so thank you very much for making that. And of course, simulations are going to help tremendously in terms of generation of the synthetic data. So Debashish, continuing that thread, okay, when we talk about simulation and continuing data set, which was not easily available or was very difficult to get hold of, right? I have personally seen a revolution. When I was studying out here, we had 2 copies of a book. You will go to library, you will be given 15 days to take it out, and then you have to make notes. Then Google came, mother of God, right? Everything changed, right, all of a sudden. So amazing, yeah. So similar kind of revolution, I believe, is coming through AI also. How, as a commercial entity who is for-profit entity, okay, and who is making tools to enhance that knowledge, set, okay, how's your company working around tools which are very specific to Indian market, which are very specific to AI-driven approach, and can be actually quantified through outcomes, okay, as to how they are improving outcomes? If you can shed some light on that.
Sure. As I mentioned in a brief introduction, is that we are basically an embedded systems developer. Obviously, when you look at Indian market and when you compare it with the Japan market, that's where they primarily are businesses. Japan market is very advanced in terms of medical electronics. And one of the objectives of almost all the technology companies over there is basically to collaborate with the research organizations. Whether it's a medical organization or it's a university. Ma'am comes from Kyushu, she has studied in Kyushu, she knows very well. So we work with various universities, whether it's Tokyo University or the Showa University or the Kyoto University and all, and wherein we collaborate with researchers who are working on very particular, let's say, diseases or particular solution for an early prediction of a particular a disease that has to be done. In a similar case, we had worked out with, there was this a group of 3 companies and 1 college. It was Showa University in Yokohama, it was Fujisoft, and the another company was Olympus, who was basically into medical imaging solutions and everything. So the idea was they had a lot of endoscopies, devices, which are there for Olympus. The idea was that how can I use AI using the ML and DL algorithms to predict the colonoscopies that is being done and how accurate they are. Because what happens is that when a doctor does a colonoscopy, it is using a very small camera, and it might miss the lesions which are there. So the idea was to take out, as in like do a research on that, create an algorithm behind it, so that those lesions are not missed out. So
and how would you do that? Like, what will be the kind of structure?
So we had a data of around 3.95 million images across, collected from various health centers, various hospitals, research centers across Japan. I'm not talking about, we didn't do the study obviously in other countries, we used only Japan as a data set for that. From that, we then figured out through the algorithm at the back end, we figured out what is the chances that the lesion has been missed or something like that. So the accuracy went up to 94%. That, you know, that this is how this particular colonoscopy went done after, we are not doubting the physician's capability at all. Our job is to assist the physician in making the right decision. A machine can never always be right. Machine is what, or an algorithm is what you have taught the algorithm to be. It is an assistive technology. It is not, it is going to assist the physician in making the right decision. That is our job. Our job is not to replace the physician. You can never replace the physician at the end of the day. But the data set that is being collected, that is giving me a better accuracy of better diagnosis in the future. Similarly, we also worked with another university of Ivy League in MIT, wherein the objective was, how do I predict that a person will have psychosis? So in case of psychosis, what we did, we collected speech, we collected their voice, and we did a speech synthesis on top of it. Okay, and then we matched it with around 40 to 50,000 users from the general public. And then we run an algorithm at the back end of it. And we were able to predict 98% that these group of people will have a tendency towards psychosis in the near future. And we were correct in most of the cases. And it helped in terms of also helping the person who was getting, be tested on that, is there any suicidal tendencies for that? Is there any kind of a mental depression the person is feeling from? So these are the kind of, solutions that we have worked upon, which is actually helping the medical industry. Today we have an AI solution for liver cancer, for predicting liver, skin, then rectal, you talk about kidney, everything is there. And right now, the solutions which are there in the market are predicting close to around 93 to 94% accuracy on that. But obviously, these technologies are very, very expensive. They are not it is not available in India. Many places it's not available in India. No, people, even if it is available in India, general people don't have an access to that. But coming to India, we run an innovation center with the state of West Bengal over here. There is a group of students over here who have created an application which diagnoses the hearing loss a person might have. By creating, they have collected a data set across Bengal and across many other states as well. They are predicting that what is the percentage chance that the person will have a hearing loss at this age. They are right now in the building phase, and hopefully by next year, they will be able to launch that application, which will be a free-to-use app for any person who wants to test that what is the chances of his loss of hearing in the coming year's time. And then they will, next step is basically then connecting to the doctor.
That's pretty awesome and very inspiring. Dr. Datta, Devashish talked about one of the challenges, the cost. You also talked about the cost being a factor, okay, especially for a country like India. What are the 3 top challenges you see in terms of adoption of AI and Gen AI concepts and solutions in the Indian healthcare context, and especially in the rural areas?
Most important challenge, it is not only for AI and ML, all those things to be in the market, which is made in India, there is a gap. Like the scientists, I was discussing with someone here, so scientists, they do their research, and we have good scientists. Like India can boast of the scientists we have in our country. So they do the research and they come up with some innovative ideas or innovative product. The main, the gap is how we can, this idea or this product can be taken up as a scaling up of the product as well as the commercialization of the product, and then further down how it can be used by the population at large. So there is a gap. So this gap, I am a researcher and I am heading a research organization. We have lot of products. I don't know, I cannot tell you about like private setup. I'm coming from government setup, so I can tell you that this gap, it should be addressed, and there should be some steps to reduce this gap. So otherwise, whatever now, the research will remain in the lab, and we will be using some imported technology or imported innovation for our country, for the use in our country. And if it is not, I told you in the my first discussion only, if it is not made in India, it is very difficult to make it cost effective for this population. So there should be, we have to keep an eye that the technology it can be transferred from abroad. It is no point that we have to innovate the technology. If the like I can give you the example of vaccines. Like vaccines, the technology usually it is made in abroad, and then the technology is being transferred to the pharmaceutical vaccine companies, and they now after that they start producing the vaccine in a cheaper rate, so that anyone, our country, like government can adopt and can the vaccination can be we all know that UPI, where the vaccination is given free of cost by our government. So in a country like India with vast population, if the technology is not made very cost effective, it is very difficult that our entire population or the general population, like what I said, who come from a very low economic strata, they can be the beneficiary of that technology. So this is first thing, and for that gap needs to be addressed. Now AI, we can use any application in the our mobile. So any app can be used, but for that again there should be the connection. Usually the mobile, we have the mobile, almost everyone is having the mobile, but if the net connection is not fair enough, it cannot be used. Like in the remote centers, you will not get the net connection. So in that case, that part needs to be strengthened. Then only, but I must say we have much improved. If you compare the status of India, our status 20 years back, now even that for immunization, what is the coverage of immunization? It is usually government takes what is the coverage? It is usually it is the responsibility of government. It should be reported that the coverage of vaccination by the population, and for that this one app is being used, where the coverage, it is the ASHA worker, they go to the community and they ask the mother what is the percentage or what is the coverage of vaccination of your child, and then it is entered in that mobile. From there it goes to the server and it is being processed in the centralized unit. So this is happening in our country. So it is not that we have to be hopeful and positive that we will be able to do this, but we have to find out some challenges that you have said. These are the big challenges made in India, but again government is coming up with incubators, bio-incubators, then startups, promoting startups. These are important, very important for addressing the gap, but like the pace should be little more if you compare our population.
So if I have to summarize that, the three challenges that you talked about is the cost of the technology, and so by having it made in India, of course, it's going to be more cost effective. The second is the infrastructure to support that technology. It has to be made all prevalent, okay, everywhere. And the third one that you talked about was the education piece, that they have to be educated, otherwise the gaps, or the transfer gaps, okay. Lab to field, that education gap. So Suparna, coming back to you, I asked you about the education side of it. Okay, let's talk about the hospital side of it, all right? So what are you doing? How are you seeing, okay, if I have to ask you 12 months, 3 years, 5 years, How do you see the AI improving the health outcomes that you are providing to your patients? India is a country where the demand of the healthcare far outstrips supply, and so people have not been that focused on outcome. आइए ऑपरेशन कराइए, ठीक होगा होगा, नहीं होगा तो नहीं होगा types, right? But the outcome is becoming, as the masses and as the population becomes more and more informed about it through Google and everything. How do you think AI is going to play a role? How do you think you intend to use Gen AI and AI in order to improve the outcomes for your hospital system so that you can attract better hold of consumers, you can provide a better experience, and you can ultimately reduce the cost of care?
See, I think the main challenge for any hospital is patient outcomes. Now, I think that I would go back a little and say that, we were using an app some time back that's called Arogya Setu. Okay, you remember that app? Everybody remembers, for COVID. So there was like an app, and it was, used in the rural side also like rampant. Now, we were like giving there like, are you having cough for last 2 days? Yes or no? Are you having fever? 100 के ऊपर ऐसा कुछ questions था. You don't know, I panicked to write those questions. I thought the moment I will fill up all the thing, you are having COVID. Or you are, in fact, they were giving you the geolocation that, where else COVID patients are there, where you are there. Like within 1 kilometer of your range, there is a COVID patient, or, there are 2 kilometers range. So we had gone that far. So if we have gone that far, I think what Debashish was mentioning, the accuracy of treatment. Now, I being a hospital head, still, if it is a medical college hospital or what hospital, everybody would, say that, we are all cost sensitive. No matter what we do, we have to be cost sensitive. Now, suppose I detect a disease earlier, I take the patient to surgery earlier, and I discharge the patient fast with accuracy of treatment, and I only give medicine. There is no like evidence-based treatment, okay? Faster it is for everybody of us. The insurance is happy. There's a faster recovery. The premiums can be well under limits. So I think the possibilities are endless. So now we have a scheme running on when Dr. Satyajit Bose was mentioning that we have been like hankered by the scheme like Ayushman Bharat, Digital Health Mission, where we are all supposed to have a EHR. And then we have in our own state, we have Shastro Shati. So now everything like they are saying, 1800 per day you will get no matter what happens to the patient. It is only 1800 rupees a day allotted if you're a Shastro Shati card holder. Now you tell me, in a hospital, a mid-level hospital with good doctors, empirical medicines, laboratory investigations, how would you see this 1800 is coming from? I mean, how can you justify the cost, or whether you are within the cost or above the cost? So I think if AI comes along with us, holding our hand, then things become easier, because every doctor, provisional diagnosis, when the patient comes to the emergency, there is a diagnosis, provisional diagnosis. To arrive at a final diagnosis, they're taking another 72 hours more. So I think those things can be addressed. So yes, so you can be faster in the diagnosis, and I think the treatment modalities can be fixed, faster. So you don't have to do this. अच्छा ये भी देख ले, अच्छा LFT बोल रहा है, उसके साथ CT brain भी करवा ले. You never know what is the relation between a LFT and a CT scan brain for a same patient, but there is. And so I think these kind of repetition of tests, or like sometimes we take second opinions, we give cross referrals. So those kind of things, I feel it can be minimized to a large extent.
Thank you, Suparna. Debashish, I'll ask you one question, continuing from what Suparna was talking about. So we all heard the cost, and you yourself said that some of these treatments or solutions are very expensive, right? So what is the industry doing, industry that you belong to, in order to kind of transfer of technology, bring it in India, reduce the cost? I heard that one experiment or one app that your students are building, okay, but that's more in the philanthropic space, all right? For commercial space, okay, what is the technology being done, okay? Oh, what are you guys doing, okay, especially your firm? And the second thing is, the thing that Suparna talked about, a lot of that requires virtual interaction, okay? So how are your technologies being handled through virtually in order to kind of support, you know, you don't have to come to the hospital for a pre-diagnosis, it can be done sitting at home or something like that?
So obviously telemedicine is very popular now, especially during the COVID period. It actually peaked. A lot of diagnoses were done through telemedicine. And in telemedicine, unless and until you're not looking at the person physically, you're just meeting him virtually. So you need to have that data with yourself to be making sure that you are giving him the right diagnosis, him or her. So telemedicine is definitely, gonna be booming in the coming years, considering the fact that we will see more AI implementation in the medical field. Now, coming to your first question, wherein you're saying that, how is India going to benefit from it? So the India and Japan have a kind of an agreement wherein there are the medical technology companies from Japan. They are going to build these devices in India under the Make in India campaign. Whether it is Fujifilm, whether it is Canon, whether it is Olympus, or whether it is any other technology company, medical technology company in India. So I think that's where the central government is very clear on the fact that, under the Make in India campaign, you just not only manufacture the device over here, but you also find a suitable partner within India with whom you're going to share the technology, and you're going to build it with collaboration within India. Because for us, we know that if I'm going to charge the same amount of money that I charge in Japan, I will not be able to sell my solution here in India. It is impossible for me to sell, because India is a market of volumes. It is not a market of unit cost. So obviously the strategy is not to charge an over exorbitant price of a particular device. Obviously anything new technology which is coming up in the market by any of these larger medical electronic companies, whether it is Philips or Siemens or GE or anyone else, okay, they're going to be expensive. So just to give you an example, robotic surgery 10 years back used to be very expensive, but today almost every hospital has it. Everybody has it. So it will gradually come down, but it's going to take us time when we reach that manufacturing excellence over here in India. The cost will go down as and when more people start using it. And I'm sorry to say, but in generally, when I see advertisements on the roads, that AI driven, so AI is a very abused word. Very abused word. Half of the 90% of the people don't even understand what is AI. So they think that, oh, it's artificial intelligence, that's it. But there is a whole lot of stack which goes behind an AI. It is just not very simple something that can be done. Robotic arm processing cannot be an AI. It is an AI, definitely, but it's just one part of it.
Yeah, because the mechanics have to be there.
Absolutely, absolutely. So we are working with various companies across the world in terms of bringing down the cost, because most of the cost goes in actually research. Yeah. And that's why the cost is high. But we are seeing how we can bring it down.
So with respect to time, this was pretty awesome. So I'm gonna ask for the one last thought, okay? And I'm gonna kind of ask a slightly controversial question out here. You guys each have 15 to 30 seconds to answer that. What do you guys think? We have all extolled the virtues of AI, how great it is, how Gen AI is doing. What is the downside? Dr. Datta?
So AI, there is some downside, like AI means it is open. All the patient's confidentiality is very important. If you think, we physicians, we have to read an oath that we cannot, the confidentiality of the patient should be maintained. But if all the information goes to some server, and so there that ethical issue will come in, and that there should be some for maintenance of confidentiality, some technology should be developed so that the confidentiality is maintained. The second thing is that AI is, I think Dr. Debashish was telling that it is after all, it is a technology and equipment based. So if in healthcare, sometimes some patient, they may not fit into the data which have been fed to the computer. So in that case, human intelligence and clinical eye is very important. So there should be we have to be careful that we should not depend 100% on AI, but simultaneously, side by side, the clinical component is also very important, and if necessary, they should be consulted. So these two I can...
I think the downside of AI is that over-reliance on the technology, because research at the end of the day is done with a certain amount of data sets. Whereas when we go out in the actual market, it is very, very wide, as Dr. Datta pointed out. It has to be something more like a learning, self-learning solution, which learns from anything which new it comes to it. What we have seen with with Tesla, as a matter of a different industry altogether, or we talk about Boston Dynamics, the robotics company, where it learns every day from what it is able to see, what it is able to gather. That will be useful. But as Dr. Datta pointed out, yes, I think data protection is very important. We have a data protection bill which is coming up, personal data protection bill in the central government is coming out very soon, which is on the lines of almost like GDPR. And that will bring in more, I think, more structure into the way it is being handled. But apart from that, I don't think there is obviously a negative side of every technology. But I think if we look at the positive side of it, it will be more helpful for us in terms of the future, because the future is definitely going to change by using these technologies. So how do we embrace and how do we protect ourselves? I think those points needs to be added first.
Suparna?
I am completely lost. I don't think so. Over-information is anyway very nice. Because see, I just can take, everybody knows, Angelina Jolie, bolo, she took her breast out, mastectomy, thinking that she should be having breast cancer. Like, it was genetic. Then now suppose today I come to know that I'll get a brain tumor, what will I do? I mean, I'll just sit quiet, waiting for the tumor to set in. When I have this kind of renovations, I don't know, I really get scared. And that day I was mentioning Debashish, I was asking, ChatGPT, I was asking why I'm depressed today. My God, she started telling me all kind of weird things. I just put a question, why am I depressed today in the ChatGPT? Suddenly, plethora of things have come out, and half of them I don't even relate to. So I think sometimes, on a serious note, sometimes I think over-information is also bad. And with this Gen AI coming in, where, images, structures, the way it is mutating, it's like it's a growing science. And your mapping is done, and you know that where you will be. So it is a little scary. So I think the ethics comes in a large way. What is our principle saying? So the ethics, data privacy, I think this too has to be taken into foremost, and then we can.
And I want to just say one thing, like, as we know, this is data driven, this is technology based, so you have to believe with a pinch of salt. So don't think that whatever it is coming, no, everything is right. So that you have to use your gray matter.
So thank you very much. The good part is that none of you talked about the existential threat to humanity itself if AI turns into Skynet and goes Terminator on us, all right? So we will stick with that, all right? So yeah, so that's good, okay? Some of the people on this planet actually are starting to think that way, like Professor Hinton, who I was talking to last year in MIT, He's the grandfather of AI, okay? He generated that whole reverse propagation algorithm in 1974. And he left his position at Google as the chief of Google AI program, right? And has started writing petitions to every head of state, okay, talking about the fact that they should not continue to develop on AI for the simple reason that it could be an existential threat to humanity, right? But I'm glad that my three panelists don't go that far, okay, and they're sticking to ethical and the data privacy.
Humans are humans, computer is computer.
All right then. Okay, with that note, I'm just gonna thank you all three to join this and appreciate that. And thanks everybody.
Thank you, Mr. Savarwal and the panelists. We have a pleasant task to perform. I request Professor Dhrubajyoti Chattopadhyay.
And technology brings it to life. Placing the right technology with the right people, we create great outcomes for good.
To the moderator, Mr. Rajiv Savarwal. No, we have. To Dr. Shanta Gupta Datta. To Mr. Debashish Mojumdar. And to Ms. Suparna Sengupta. I request all the panelists and the moderator to please be on the dais for a photo shoot. Thank you. We will now move towards the last session of the summit. Enabling investments in health and biotechnologies. I request
At PwC, knowledge fuels change, and technology brings it to life.
Please join us, Dr. Debashish.
Placing the right technology with the right people, we create great outcomes for good. The farthest corners can now champion the newest ideas. PwC guides businesses to create enhanced value through cost optimization and transformation that can galvanize the dreams of millions. Secure and seamless networks can safeguard organizational value while empowering an entire nation. Sustainability can sow the seeds to a new reality, a better tomorrow. And it all comes together to create an aspirational, empowered society that operates on renewed trust. It is how at PwC, we use technology to enable our people to build a tomorrow starting today.
Good evening, everybody. So we are in the last panel discussion. You know that the title of this panel given is the Enabling Investments in Health and biotechnologies. So far, I think the whole day we are discussing about the different aspects of the pharmaceutical industries. Pharmaceutical industries right now is very much related with the biotech industries also. Now how the relationships are going to be established and how these two can actually need some sort of combination, collaboration between these two are very important. Now, one of the key drivers of progress in health and biotechnologies is sustained investment in research and development. Now, government, private enterprises, philanthropic organizations all play pivotal role in providing the necessary funding for the scientists and researchers to explore this. And to attract this private sector investment, regulatory framework must strike a balance between ensuring safety and expediting the approval process. And predictable and transparent regulatory pathways reduce the uncertainties associated with the product development, making investments more attractive to private entities. Now, in this panel, we have three very important personalities with us. One is Dr. Debashish Dotto, who is the Chief Executive Officer of Kolkata Biotech Park. The other one, we have Dr. Shangita Majhi, who is actually from the area head of analytical facility of IKP Knowledge Park, Hyderabad. And Dr. Borun Kanda Bhattacharya, who is a manager R&D, East India Pharmaceutical Works Limited. So these are the three panelists with us. Keeping these three panelists in mind, I want to do some sort of reverse way of discussion started. You know that I need certain questions from the audience, and these questions I may ask to the panelist. So if you can actually think about this particular panel and have some sort of questions in your mind which you expect from the panelist, if there is any question specifically, because that will make our life a little bit easier, the participation of the audience in the panel discussion. Questions from the panelist. Anyone? Then we can start. Yes, start. Microphone, please. So I shall take the questions first. Please listen to that, and then a couple of questions I can start the discussion. All right? Yeah.
Thank you, sir, for this reverse flow. Yeah. So, yeah, I'm Shonali Roy. I'm from ISAR Kolkata Incubation Center. I'm leading the incubation center, which is named at Research, Innovation and Scientific Entrepreneurship Foundation, ISAR Kolkata. So, I'm dealing with the startups in specific eastern region from ISAR Kolkata for last 1.5 years. And before that, I was dealing with the startups in Northeast India. I was in Naipur, Guwahati. So what I feel that in comparison to other part of the country, our startups is not yet investment ready. So what our panelists can enlighten us that how should we make our startups investment ready before asking for the investment from the private or the government sector?
A very, very good question. Yes, thank you, Shonali, for this question. Any other question? Yes. Any question? Yeah. Can the microphone go over there?
So thank you so much for giving me this opportunity. I'm Professor Shoikat Maiti from System Debate University. So I'm basically dealing with the AI and ML part. So being a professor of this computer science and technology, I have I found a kind of challenge in because we people are dealing with the biotechnology, we people are dealing with also the agriculture part, microbiology part. All the parts are associated with the ML and AI part. So what we have seen that one part is very important, which is data acquisition. So data acquisition requires a lot of hazards that we people are facing whenever we are going for any kind of research, especially for the ML part, machine learning part. And machine learning plays a vital role in this particular biotechnology and microbiology part. So is there any alternative resource where from we can take the data acquisition, or rather we can acquisite the data from the different means microbiologist or biotechnologist, as well as we are also running the incubation part, though the pre-incubation is not getting readily funded by the different angel investors or the other funding parties. So my question is how we can able to overcome these two problems. These are the very vital problems that we are facing nowadays. So data acquisition, and the next point is pre-incubation.
Sir, here I want to mention one thing. The first question, you're talking about the data acquisition. You are talking about taking the help. I'm not clear. You're talking about some personal, some microbiologist or some researcher you're talking about, or some agencies that will be government or private?
No, I am just asking about a kind of data set which we are taking right now from Kaggle. A real-time data set, if you'll find, that will be much easier for us to means.
Can you please define the source?
We'll come back to that.
Okay,
Yeah.
sure, sure.
Any other question? Yes.
Good afternoon, sir, and panelists. I am Dr. Saptarshi Chatterjee. I am from the E-UVA Center, Adamas University, which is a pre-incubation center supported by BIRAC, Government of India. My question to the panelists would be that we see that most of the research investments in India come from the government, while most of the startups who sustain are privately funded. So when can there be an amalgamation of private and public financial support for a research that will be in an academic institution or that will lead to industrial development? Thank you very much.
Very good questions. Any other question? Though I have got 3 questions already, but if there are any other question of a little bit different nature? Okay, if there is no more question, I shall go back to my panelist and I hope the panelists, you remember the questions. Regarding the startup, which are yet to get the investment ready, can I request Shangita that, because in the IKP you have already quite a bit of experience in Hyderabad in your sector regarding this, if you can give your experience, share your experience.
Yeah. So, hello, I am Shangita. I am from IKP Knowledge Park, which is based in Hyderabad. This is our first life science park actually, where we provide the laboratory space. Large company, mid-size company. Now I'll be talking about startup. So we have incubation facility where we provide the incubation facility with common infrastructure for their equipment. Equipment infrastructure, so that when startup come and they start working, they don't invest in the equipment part. So the question is now that they are not investment ready when you, Sonali, when you meant that it is like they are at some stage when they are looking for investment. So in our incubation center or any incubation center, when startup comes, initially they can come for with their own bootstrap money, and then we provide them some seed fund, which is coming from maybe DST, DBT initial days we have gotten those seed fund. So initially we provide them that 10 lakhs to 15 lakhs to 20 lakhs of seed fund when they prove their concept. So when they are at the stage of proof of concept, then they can go for second round of fund, which is now BIRAC, BIG grant is one grant, what is basically to take their technology from TRL 2 to TRL 3 or 4. So by doing all these things, when their project is more or less ready, then we can go for pitching to the investor. And in IKP, we have a mentor pool where we help them to how to pitch to the investor, angel investor, or any other round of investment. But before doing that, they have to definitely prove their product to at some stage, minimum viable product and all. For doing that also, seed funds are available, what I can say.
Yeah, I think this is a very important thing for the audience who have these questions in their mind. If your startup is, you have that startup and you are looking for investments, if you can prove your concept, that particular thing, and then the IKP is going to provide you that particular fund for the first stage, and then after that there are other bigger funding institutions like the DBT BIRAC, who can actually give you something which will take you from the pilot to the some sort of mid step one, and then you can get the VC for the venture capital. You can move on to that. So thank you. But any other panelist has got anything to say? Debashish?
Yeah, I want to mention that is what Dr. Maji was talking about, that is the funding from the government end, right? So I have my personal experience is talking about that the investors from the private end, that means that is the part is very much available for the VCs, means your venture capitalist. That is the northern part of India and western part of India. Still today that concept is not too much in this half of India. I am telling that the recently for some program we have visited Delhi, they are the persons has been ready to jump for the investment purpose. They wanted to come in the biotech park and they were ready to come over the night, that they are ready to invest it. Because keep in your mind simple, that is their work. The whole day and night they are doing this is. They are ready to pump their money, but they want the ROI, that is return on investment. So if you are ready to jump in this particular pool, that means if you are confident about your ROI, then these kind of investors are being there who are ready to invest for you, right? You have the potential for this, right? Thank you very much.
Over here, I just want to mention that in the last panel, Professor Shanta Datta mentioned about that there are numerous research institutes and universities where very good, commendable research is going on. But this research has got no direct connectivity with how this could be raised to the extent that it can form the startup or it can actually go to the market. So making that, there should be certain efforts should be taken about it. And over here, I have Dr. Varun Bhattacharya, you know that he is one of the pioneers in the East India Pharmaceuticals, one of the very important pharmaceutical company of our state, to set up the R&D laboratory for the biotechnology development. And there, what's your experience regarding this?
Sir, for a development of a product and development of a molecule is a different ballgame. If we develop a product and if you develop a new molecule, this molecule when we transform into a product for a targeted disease, this is a different ballgame because we have to formulate this in a product. The formulation part and the delivery part is different ballgame, and you have to pass the regulatory guidelines because in our regulatory guidelines we have 4 segments of BCS classification of products depending on its solubility and permeability. So there comes the clinical trial issues. Maximum products which fall into category 3 or 4 needs for the details clinical trial. And for any product development, total establishment of a product from the laboratory bench work, the 80% money needed for clinical trials. So there the equation starts. So when we got the permission, apply for the marketing and manufacturing license, we have to go to the DCGI. So we have to present ourselves the detailed data in front of them. There is a subject expert committee there. Suppose we have a product positioned towards the gastroenterology. We have to face the board of examiners for eminent gastroenterologists of India. They will raise questions on your data and then they will suggest that what type of clinical trial is needed for this. That may be phase 4, maybe phase 3. Phase 4 is okay for our pharmaceutical companies because it is based on pharmacovigilance studies. That is phase 4 after marketing. But if it is phase 3, it needs detailed clinical trial. And at least for the, we have 4 segments of products. That is modern medicine, biotechnological products, Ayurvedic medicine, and recently we have launched personal care products also. For modern medicines, nowadays the regulations are so stringent that, say for I'm not naming that product, we have one product, probiotic. We have already DCGI NOC for capsules. We have applied for sachets. That is a powder variety. Those persons are babies who cannot take these things. So we have prepared the sachets and we have applied to DCGI for NOCs. They have imposed on us 10 clinical trials on which indication, 10 clinical indications which we have claimed for this. That means at least 3 to 4 crores of rupees. This is the tragedy of things that we are facing, the pharmaceutical association, for a single probiotic sachet. So if we discover a molecule that is showing efficacy on our basic experiments, then we have to go to the clinical study, pilot scale studies. Then you have to get the permission from the regulatory authorities to produce it. That means you have to get the test license. Nowadays, for getting a test license, you have to submit them details, stability studies, details pharmacological studies, and then you will obtain the test license. Say, for example, we have to produce 20 or 25 kgs for a pilot trial, details clinical studies or stability studies. Then you have to apply for the marketing and manufacturing license. For depending on the region, we have to test the stability studies. We have ICH 4 zones. Suppose if you put it in 25 degrees, 60% RH, then you have to run these stability studies for total shelf life. If it is a biological molecule, we are talking about the biotechnology. The chemical molecule, we can do the accelerated studies. But for biological molecule, we have to go for real-time type stability studies. For live cells, proteins, we cannot go for the accelerated studies.
Okay. So over here, can I actually ask Debashish that you know that say scientists in different laboratories, they have certain things, certain findings which are very, very important. Do you think the Kolkata Biotech Park can have one of its policy to identify the different work done by the different institutions and go to the institutions and find it out that these are the scientists who are working in this way and whether you can help them in that regard? I think, Professor Dutta, you are also thinking about the support from the government for getting the scientists so that their work can go from the laboratory to the public market.
Actually, if you have to follow government rules, then it becomes a bit difficult. But like any product, if it is developed in any lab, then if you want to take it to the market, you cannot talk to, personally you cannot talk to any of the company, like this marketing company. So that has to be announced, that is known as EOI. Like we have to invite you have to announce it in the website, and EOI has to be called for, and then they presume that many companies will show interest, but that end up with even one single company also does not come up. So that is the issue, but these are the government procedures that we have to follow. Rather, that is the reason why I was thinking, like, a company may show the interest one-to-one basis, like if they have the, they understand the credentials of the lab, and also they have the faith in the researcher, then they can talk to the researcher. They are ready to pay also to take up the molecule or the vaccine for marketing and for scaling up. But government will not allow the researcher to do that. So, this is a
How
kind
this
of
problem could be. No,
It is-
that's
it
why
is
I
a
said,
problem.
yeah, that's why I said the government of West Bengal, it set up this Kolkata Biotech Park. So it's a government. So from the government part, if they actually approach to these institutions and others, that whether you have some very important things, findings or anything, so we can help you in developing this type of things. Do you think that Kolkata Biotech Park can do that?
Yeah, I'm very much to sir that the sir is asking me the question. This is very much pertinent. First thing is that at the Kolkata Biotech Park under aegis of the Department of Science and Technology and Biotechnology, West Bengal government. So whatever the protocols are from the government has been said, we have to perfectly follow that. So here there is no deviation from our end. We cannot do that. So whatever the things you are telling, EOI, expression of interest, to put it in the website, to put it in the newspapers, all these protocols we have to follow. We have to go through the GEM, that is the government e-market. We cannot deviate from there. Yeah. What are the things we can do that I have talked to the several incubators like Shonalidhi and Dr. Chatterjee, right? They're very close, very close vicinity. They're working with us that, yes, the persons who are very much keen to develop the product, right? Maybe from the government, maybe from the private. Honestly speaking, I do not want to name in the forum. Some of the professors from the Calcutta University, they came to us. They told that, okay, fine. Some of the other very much close persons to them, they are starting out the incubations, so there is a startup. So we have to do the certification for that. Okay, they are been doing the research in the biotech park. We are taking care of that. Yeah, it is true that the Kolkata Biotech Park is just has been started. But out of the few of the biotech parks, we have moved above of the few of the biotech parks, just like your others, those who have been very much older one. For giving an example for the affiliation purpose, research partnership purpose. But whenever they are coming for the research purpose in our park, they must have to follow whatever the government protocols, that is the things being laid down by the bureaucrats and the scientists in the board. That are the things we cannot avoid. We can try to accelerate those, right? But some time has been there, we have to follow, and that the things we cannot avoid it. Right, ma'am?
Thank you.
So we can move on to the next question, which is from a computer scientist. Now they are more interested for data acquisition, and this data acquisition is a challenging thing for them actually, because you know that whatever though the medical informatics, bioinformatics, clinical informatics, it's there for a long period of time, but actually what it means and how it's going to be translated in reality, that is somewhat, because there are so many legal protocols and many other things are there with respect to this. But there are many data, say for example, libraries and other things are available, which you can purchase also. So for example, for getting a molecule, there are a huge number of chemical molecule data available in library. From there you can identify the data, you can get it. The data acquisition for part of the other aspect is also very important. And over here, do you find IKP face similar type of things, and what is actually your comments on it?
AI-based this kind of data acquisition company.
Okay.
Never came in our.
So do you think there are data acquisition companies or anyone else?
Our complete concentration on life science companies, so pharma and biopharma mostly.
Mm-hmm.
So we never dealt this kind of company who are
Mm-hmm.
this kind
Debashish, what is your comment?
Yeah, so here I can very much happy to answer this question. This question is very much important. What Professor Maiti probably was asking and Sir was supporting, that here, still now, IKP has not done this. IKP is much more older than us. I have dealt with a company, you can say is not a company, you can say that it is an effort from the government end, that is NDLI. Anybody has heard about NDLI? Anybody? NDLI, National Digital Library of India, right? So I was heading that under leadership of Professor PPC. That time the director of the IIT Kharagpur, I was heading the particular project. Data can be stored in your server. You have to take the permission from the data provider. What we are trying to do in the NTLI, that source was giving us the data that was being stored in our server, in the IIT Kharagpur server, and then what the things been happened that the people can, without any cost, can access. Even today you can log in and you can access the data. It is completely free of cost. Any kind of video, audio, writings, anything, right? More than 10.5 crores data has been there, but that the things can be done with the prior permission from the source itself. And if source is saying any of the moment that I do not want to further put the data in your server, they can remove it. So whenever any of the user is clicking the data source, immediately that host source is connecting to the particular source, particular server from where the data has been accessed, and through the mediator, the data is supposed to be accessed. But there should be a stringent guideline of the agreements. Yes, data can be up to this is the time you can access. And following all the legal IPRs, right? We have some of the data we have prepared, and maximum of the data, almost 90% data of the 10.5 crores, it has been accessed from any other sources, those who are agreed to serve the data. Right, sir?
Yeah, but this is not applicable to medical data.
Here, ma'am, I want to mention that TMC, that is your Tata Medical Center, right? So the one project was there from the IIT Kharagpur. Professor Mukherjee was the PI of that, right? So that particular project was dealing with the medical image processing. Data has been available there. The project name was CHAVI, C-H-A-V-I, CHAVI, right? This is an acronym of the entire things. I forgot the things. So medical image, entire data has been accessed, those who have been required the data. I do not know for the other things, but TMC was agreed to serve the data in the particular server. Right, ma'am? Yeah. So that's why medical image data has been available. Yeah. All the ethical protocol you have to follow. You cannot download, you cannot distort, all these things have been there. Right? Data has been available.
So I think it's a positive note. So from here we can actually move on. Professor Maiti, you could get this particular idea about it. I think you can come up with, I'm expecting that you should come up. Microphone, please. If the microphone.
Hello, everyone. Actually, confidentiality of data in case of medical informatics, since I'm working into the subject, is more of misnomer, really. If there is a data without the tag of a person, then it is available. It can be shared. If you don't share the medical data, then there is no use of storing the data. You have to work on the data, right? But sharing the data, in our company, what we have taken up is that we'll mask the identity of the data. What is the identity of the data? Your name, your father's name, address, etc., etc. So if we mask up and record number 1, 2, 3, 4, then pulse, pressure, blah, blah, blah. Whose data is this? And as long as for being a company, we vouch that this is real data. There are a lot of cases that using this kind of technology, people are giving fake data. In that case, onus is on the company to vouch that this is real data. Then you can always share the data. Until and unless you share the data, the very purpose of medical informatics, very purpose of collecting the data falls apart.
That's why the question comes about how popular is the medical informatics in our country, in our state. We have taken any particular step in that direction?
Right.
Do you have any idea?
No, actually, whatever in the company, in the hospitals, individuals' clinical data is collected, they generally sign up a kind of disclaimer that we are.
That they are doing actually.
They are doing actually.
Mhm.
So that's it. No, there's no specific clause or law in the country. I don't know.
I just want to get this answer from you also, because you deal with quite a bit of legal part of the whole thing.
So hello, I'm Harshada. I work with IKP Knowledge Park, the Regional Tech Transfer Office of IKP Knowledge Park. I'm an engineer turned lawyer. So this data part we usually deal with, and currently there is no regulation which is handling. So the Data Protection Act, which was mentioned in previous panel, it is coming up. But there is no law as such. It is only through contracts law, which is happening right now. There is also no regulated marketplace. I know Apollo, the prime sponsor here, has made a lot of money by selling this data. So data is available to the startups who are, there are quite a bit of startups who are working in this domain, especially for LLMs, language learning models. You have to give the input of multiple data, and as ma'am rightly mentioned, it shouldn't be, the identifiers are removed. So the data shouldn't be linked to specific person. Anyone cannot be identified using the data. Other than that, it is fine. So currently, Kaam Chalao type, it's working. Only contract law is there. But I think for the panel members and audience here and the organizers also, I feel like, you know, a paper or something like a policy suggestion should come out of this, because we do need this regulation in a very structured manner, so that startups or research or innovators who are working in this domain will have certain SOP to follow. So guidelines
Very, very
will
important suggestions, and I think our CEO Saab is actually taking a note of this, because you are in this particular job right now in the policy formation by the government of West Bengal.
Yes, equally tagging up data with a particular person's name. If that is removed, then data is open. Now nobody can have the ownership of the data. That is there.
Yeah.
Thank you.
So now we move on to the last question. And this question is very vital actually. Amalgamation of public and private in helping the startups. Now over here, I just want to get the comments from Dr. Barun.
This is a very welcome approach. But from the industry part, what matters that the stake claimed by the government, because the part we are marketing this product, majority of the cases we found that the part developed by the, I'm not hurting anyone, but the part is the deliverable product curing a disease is different rather than discovering a molecule that I have told earlier. But when we are going for the formulations, for developing a product, we face different difficulties. And what will appear that it is a different product in chemical nature, what appeared in the originally what is proposed, and when after formulation it will be a different molecule for making a product, for bioavailability or bioequivalence studies.
Different parameters are going to be there.
We have to pass for drug control license. So then we have to satisfy the stake from the government. So this is a very delicate balance industry has to maintain, and this is a thing that we have to sort it out.
But I think IKP, you have done quite a bit of this public-private amalgamation.
So what was the question exactly?
The question is that, you know, that we are talking about the startups and other things. So over there, you know, the need of money is there. Now, over there, that if there is an amalgamation of the support from both public and the private to make these particular things to happen, it will be easier actually for future.
So startup, like who are working with their own money, like private Like private funding, like that is investment only whoever coming from the investor or whatever. But partnership with the government, like mostly we are getting government funding also. Like with that, if they are going to the next stage, then as I said, then comes the private investment to scale up and going to commercialization product.
So BIRAC can be taken as one of the example because
So
over there you
funding,
can have
yes.
both the
And then
support.
So then nowadays, like where we are facing major challenge for the startup is the scale up. Like Sir was mentioning API, when it is in a API stage, it's a bit different, and then when it will be formulated and then scaling up.
API is ready for use for formulation.
And then
But,
after formulation, all your...
No, the API, you have to get it ready for API. So it's for extraction. Suppose you propose a product X, but it is not soluble in water. Or for bioequivalence, it has to be get more soluble or more available in the body. So we need to change some chemical modifications in it. We have to add some things. So it's a different molecule altogether. For making a product is
So I am talking about from the investment side, like
BIRAC is an excellent example for COVID situation.
Yeah.
BIRAC is helping more
Yes.
for production of vaccines
so,
or
like
these
product
things.
when it is ready, like BIRAC now another scheme is coming. What I was going to tell, that when startup is ready with the product also, where they are facing the challenge to scale up. So now different schemes are coming where when actually yesterday from DST two investment came to two different domain. One is BITS Pilani and another one is Mumbai cluster, where they are giving 60 crores to make the manufacturing facility.
Oh, that's a very good news. Now
Yes, to
the
help
university
this
is receiving
startup.
that. Yeah.
So that is one institute cluster actually. It's chemical technology, then TIFR, IIT, and two more institute together. They got formed a cluster where they received 60 crores. That is to accelerate the startup for the going to the next stage. So when we are talking about, so this is from government side investment if we think. So they can go to the...
So which is also important, and I think everybody, we should be very happy with it, that there are possibilities of this type of support from the government. If you can actually, so when we started with the concept of enabling investments in health and biotechnologies, the one of the recent example is just yesterday's DST thing, where they are giving two different supports. So over here, the government supports are also there. We are also looking for the support from the private investors also. Any example of private investors?
Can I? So there is a scheme of BIRAC, maybe Sangeeta Di can say better, fund of funds. So in that, private investments and government investments all come together, and then the committee decide that who will need the fund to go for the marketing and scale up phase. So there is a fund of funds from BIRAC.
So this is a very important thing for whoever is interested in this, and to come up to this conclusion of this particular session, where we could find that yes, there are possibilities of getting this type of investments from both the government support as well as a private support. And for that, we have to be very clear about what we want, about our concept of proposal, our proof of concept, and all these things. So I shall end with our CEO, so because yes.
Yeah, I have such experience, but I'm very sorry to say that usually those startups, if it is formed by those institutes that BITS Pilani, IIT, and all those institutes are concerned, like the startups are actually formed by alumni or the students of those institutes, then only government gives the fund. So
you think it's a bias?
I think that scenario has changed, because I am sitting here from a private university which is just 8-year-old and which has received fund from government. And two highest agencies, one is BIRAC, and we are also coming up with a Niti Aayog fund. So I think that scenario has changed. But again, what ma'am perhaps wanted to say is the success rate is still higher for this also. Absolutely.
Anyway,
So,
we have to find it out.
So I mean, in continuation, this that amount of fund, it's not, I mean, different. So you know about maybe KIT TBI. They received funding from maybe almost all the government agencies. It's in
Odisha,
KIIT,
Odisha.
Odisha. So and then IKP, they got much funding from almost all the ministries. It's a private entity.
And
yeah.
one
So
last
there
thing.
are many examples where if you do well, so you can get. But in this case, especially this one, what Dr. Maji said today, I mean yesterday it came. It's a cluster of institutes. So maybe probably in future West Bengal can also see this type because we
Yeah,
are
that's
trying
why I
in
said we will end up with our CEO, sir, that let him actually convince the government of West Bengal that they should also come up with this type of funding policies.
Yes, and for Kalyani, we are trying that, as you know, Adamas, ISER, AIMS, IIIT, NIBMG, Kalyani University,
That's a hub.
BCC, and
It's a hub, 7
MacOut. We have made this Kalyani Innovation Network, and we are working to make this type of facilities and help to the startups, maybe from the institutes and out of the institutes. Anybody were welcome here.
Very good, yeah. Yeah, so end up with Debashish.
Yeah. So in the very nutshell, I want to finish it. But because, see, if it is talking about the private and public investment together amalgamation, see, it will be the best. We are running a very good system in India. Can anybody, please, from the audience, can tell that the private-public partnership is going and in education doing very good, beautiful? IIIT, Indian Institute of Information Technology. This is a private-public equity, right? They are doing quite well. Few of the IIIT is doing much more better than in any of the departments, even the IITs. So we have to go in tandem. Definitely, private as well as the public, both the funding is required for development of us. Me personally is trying to give a very high level of trust, and my request to all of the stakeholders to the biotech park, the first biotech park in eastern part of India, to support us so that we can get this kind of opportunity. And whatever side is telling is a really dream for us one day that the West Bengal will be pioneering in this particular industry. Thank you so
Great.
much.
That's a very good actually information for all of us, and we will look forward to this. With this, we are going to end this session, and I'm sure that BCCI can take a lead in this and also can be what I can say, a facilitator in having more consultation with the government, with the private as well as the chamber, the different business communities, so that we can really see what we want today. We started this session enabling investments. So which we'll see some investments together by both of them. Thank you very much, and thank you to all the panelists. Thank you the audience over here for beautiful questions. Thank you. Namaskar.
Thank you, sir, and thank you all the panelists. Now we have a pleasant task to perform. I request sir to please present mementos to the panelists. To Dr. Debashish Datta, to Ms. Sangeeta Maji, and to Dr. Barun Kanta Bhattacharya. I now request Ms. Sangana Gorai Chaudhary, Assistant Director General from the Bengal Chamber, to please present memento to Professor Dhubajyoti Chattopadhyay, the Chairperson of the Biotech and Pharma Committee of the Bengal Chamber and Vice Chancellor from Sister Nivedita University. I request all the panelists and sir on the dais, please. Thank you all the speakers and the panelists for joining us today, and also the audience. Lastly, I also thank to our partners for supporting us: Apollo Hospitals, Linde, Jagannath Gupta Institute of Medical Sciences, Juventus Pharmaceuticals, Narayan Memorial Hospital, Woodlands Multispeciality Hospital, East India Pharmaceuticals, IQ City Medical College and Hospital, Peerless Hospital, Ruby General Hospitals, Sister Nivedita University, Webble Fujisoft, the Senior Living Partner, Infinity, Incubation Partner, Webble BCCI, and of course Presto, the gift partner. Thank you all.